Please start, sir.
So, a very good evening to all our viewers in India. A very good morning to all our viewers in the US and across the world. A very good afternoon, a very good late evening in the Southeast Asia region. So, myself, Dr. Gaurav Luthra, I'm representing Intraocular Implant and Refractive Society of India. With me is Dr. Kumar, Doctor, who is past president of IRSI as well. We would like to welcome you to this interesting international webinar where we have some of the topmost experts from across the world here to share what they will be, or how they are doing things differently in cataract surgery over the last few months. And they are all leaders in their own fields. And we have an amazing panel of experts who will be talking about. I would like to introduce you to some of our panelists and speakers today. We have Dr. John Chang there. John, would you like to wave at everyone? He is president of the ISRS, the International Society of Refractive Surgery from Hong Kong, and he's a prolific cataract refractive surgeon. We have with us Dr. Ajoy Paul, all the way from Calcutta, and he's again an amazing cataract and refractive surgeon, and he's going to open the innings for us today. We have Professor Samuel Masket from the US, who has been nice enough to join us today, and he will be our international expert panelist and helping us to go through these take-home messages that we are going to have today. We have Dr. Ron Yeoh from Singapore, and he's no stranger to our webinars. He is, good friend of our Indian meetings and webinars, and has always been very supportive. Thanks for joining, Ron. And we have Dr. Rohit Om Parkash from Amritsar. He's the organizer of the very popular, winter meetings of the IRSI at Amritsar, and again, a great surgeon and a pioneer. We have with us Dr. Kendall Donaldson from the US. Again, she's going to show us some amazing videos. And thanks for joining us, Kendall. She's been recently back to her surgical work in the US and will share tips on how we can do it better. And we have with us Ashvin. Again, Ashvin is our star speaker from India who has been pioneering lots of new techniques all the way from Chennai and is one of our most well-represented speakers in the international forums. We have with us Dr. Sourabh Patwardhan, who's again a young, dynamic surgeon, keeps coming up with all the new techniques, which we would love to hear from you. We have our experienced past president of the AIOS, Dr. D. Ramamurthy, who's again a prolific cataract and refractive surgeon, and will be sharing his wisdom with all of us. We have with us Professor Mahipal Sachdev, who is not only the president of the All India Ophthalmic Society of India and very keen academician and surgeon, but also the chairman scientific committee of the IRSI and one of our strong men of Indian ophthalmology. We have with us Dr. Namrata Sharma, secretary of AIOS, the Iron Lady, as I like to call her. She's always coming up with she's so hardworking. I was speaking to her 2 days back that, you're during the lockdown, you've probably started working even harder for the society and for ophthalmology. Thank you, Namrata, for joining us. We have with us Dr. Kamal Kapur, who is again one of our dynamic surgeons from Delhi, from the Sharpsight centers. He's an excellent phaco and refractive surgeon, and again pioneers lots of new techniques. We have the president of IRSI with us. We are lucky to have Dr. G.S. Dhami from Ludhiana. And he again has been, my teacher in many ways for so many new things that I've learned. We have Dr. Krishna Prasad Kudlu, again, a very good refractive and cataract surgeon from the beaches of Udupi. And he's again been a very, very prominent cataract and refractive surgeon, an office bearer in AIOS. And I hope I've not missed anybody, but I missed SriGanesh. I'm sorry, Sri. I was trying to go through the maze of all the things, and I think you moved up the order. So I'm sorry for missing you. So last but not the least, we have Dr. SriGanesh himself. He's again a big innovator, a pioneer. He's a smile trainer, training so many other people in so many things. So we are so lucky to have Dr. SriGanesh with us. Again, I'm hoping I'm not missing anybody, but please excuse me if I have. We are joined by an amazing panel, and Dr. Kumar, my colleague my colleague and dear friend from Mumbai, who's again from the Doctor Eye Institute, the Doctor, and famous for his phaco videos and his LASIK training programs. So Kumar and me are going to lead you through this. We have some amazing cases lined up for you some amazing pearls which will bring you home lots of messages, things that you can adopt. And without wasting any more time, we will invite our first speaker, Ajoy, to please go ahead and start with his presentation, and then we'll have a small discussion. We have a comment section as well, so please feel free to keep sending in your questions. We are going streaming live on Facebook and YouTube and several other channels. And besides that, we have the J&J Johnson & Johnson channel, which is streaming on I think web 365. The link is there, of course, which you would have got, and you can put in your questions there. We will also keep taking on polls for which pearl you like best, so our audience is happy to participate in our discussions as well. So Ajoy, there goes, it's all yours.
Thank you, Gaurav. Thank you, IRSI, for inviting me in this. Thank you, Amar, Dr. Mahipal, and Dr. Dhami. Well, this is a unique webinar, and I'm proud to be in it. And we are going to have some international and national top-notch surgeons. 2020, that's the topic. What am I doing differently? And I'll be focusing on subluxated cataract. As you know, subluxated cataracts are complicated or challenging situations. First of all, are you going to do them in 2020, or almost we haven't done anything for the last 50 days? But yes, probably down the line, probably for first 3 months, probably won't be touching, except when they are, they have vision threatening, like the lenses come in the anterior chamber or lenses on posterior chamber. But these cases probably can wait. I just suggest some of the ways that I would innovate to get the least complication. The manual capsule is what we have been doing. Most of the way managing central foldable monofocal IOLs is what we have been doing. The railroad technique of putting in the CT set see on me having a part of the way we, but then we had to have our agonies with capsulorhexis. Almost a third of the case, I would say.
Ajoy, can you pause for a moment? Dr. Ajoy, can you pause for a moment? Ajoy, can you pause for a moment?
Most of the time. And
Ajoy, can you pause for a moment, Ajoy? I think there's problems with the internet connectivity, so your video and your sound is coming like staggered and broken up a little bit. So if you want to switch off your video and just stay with your presentation, that might help a little bit. And maybe you can just go back a little bit on your video and show us again, because we lost some of your we could not see it. So can you please go back a little bit? In fact, right now your screen is frozen. So yes, I don't know if yeah, I think we've lost him. Have we? Maybe we've. I don't see him.
The internet connection issue, sir. We can.
Yeah, so I think we've lost him. Maybe what we can do is, and in fact, his screen is shared, so we'll have to ask the admin to, disconnect his screen from the system, and we'll probably take him back. We'll take him back.
30-40 seconds. It will take 30.
Yeah, we'll take him later. So maybe we should go on to our next presenter, and let me check who is next on our list to present. Okay, Sourabh, are you ready with your presentation? Backend team, can you please switch off Dr. Ajoy's shared screen and
if video freeze, it will take 30-40 seconds.
Okay, we'll wait for that much time, and we are sorry that I think India is having a storm, thunderstorm at many places, and probably the internet connectivity is a little fluctuating at several places. That's what we've been told. So please bear with us for a few seconds, and I'm sure we'll have.
Yeah.
Okay, Ajoy is back.
Yeah,
so,
I'm
Ajoy,
back.
Would you like to? Yeah, would you like to share your screen again and start off with your video? Yeah.
The audio is much better now.
Can I? Is it?
We can see you, but we don't see your video yet. So
I think somebody else is already sharing.
No, it's actually your screen only which is still shared. It will take a few seconds to go away. The admin is going to disconnect your screen sharing. Yes, now it's gone, so you can upload your screen again. You can share it. Thanks, Ajoy. Yeah, and thanks all the audience for bearing with this. These are the ways of the new way of living that we have.
I think when did I miss?
Okay, we have it, Ajoy. Let's go
You
ahead.
have to
Yeah.
start from the beginning. I
You'll have
think.
to start from the beginning because we missed your videos. So please
okay.
start again. Yeah. Thanks.
So subluxated cataracts, as you say, in these trying times, are you going to do it as you had said, and probably wait?
Request you to just stop your video and then.
Dr. Ajoy, can you switch off your video because that is taking away some of the bandwidth?
Some sort of, vision threatening, like the lens going anteriorly or yeah.
Thanks. Thanks. Go ahead. Yeah.
Okay, now?
Yes, better now. So you
hear
can,
me?
yes, we can hear you. We can hear you. Please play your video.
Hello?
And you can switch off the audio from your video. That will allow us to hear you.
Okay, okay.
No, we've lost the screen sharing now. Can you share the screen?
But I can't see my video again.
Oh, so we don't see your screen sharing right yet.
I think
let's
start and
Ajoy,
bring Ajoy back.
So what we'll do is, Ajoy, we'll just come back to you in 15 minutes. I think there is some connectivity issue and maybe we can ask Dr. Sourabh Patwardhan to start his presentation.
No, you can, Jasminder, I think you have to come in because I can't see my video. I can see it running.
No, so your screen is not shared, Dr. Ajoy. That's why you can't see it, Your screen is not shared at this time.
Sourabh, you can get it?
I think, yes, you can try, and Ajoy will take you right after Sourabh if things are working out fine, and maybe till then Jasminder can help you with, yeah.
Yeah.
Sourabh, if you can. Okay.
I will share my screen now.
Sure.
And,
sure.
Can you see that?
Yes.
Yeah. Okay. So thanks a lot, Dr. Gaurav, for inviting me for this talk, and I am quite fortunate to speak amongst those whom I've seen and I've learned from them a lot. So I'll be sharing few pearls of which I'm doing little differently in last maybe couple of years. As I also train fellows and some of the trainees, I think apart from this, of course, which we are all doing, I think recently since we started OT. What I'll be sharing might be very basic for many, but I think it helps a lot of youngsters to learn, and maybe it will help them to make their surgery a little bit easier. So this is the first pearl which I learned. This has been already published by Dr. Zoen, and here instead of the standard two-step bend cystitome, what I'm using is a three-step bend cystitome, so which makes it more ergonomic. And for doing CCC, particularly from the main incision, what I realize is that many young surgeons do not have good control over the cystitome, and then the visco tends to leak from the main incision. So if you have this kind of three-step bend, then what happens is that when they are putting the cystitome through the incision, the anterior lip of the incision keeps tented up when they are doing CCC, and that avoids the visco leak, particularly when you are using methyl cellulose, which we commonly use for our phaco procedures. So I think this I thought was useful for me. Second is the visco press test. So many times when I used to get this kind of white cataracts, I used to operate in such a way that considering it is an intumescent one. But nowadays, what I do is that first I inject Hylucoat, which is similar to Viscoat, and what I look for is the anterior capsular flattening. So in this case, for example, as I injected the Viscoat, I found that the anterior capsule became flat. So even when I touched the anterior capsule, you can see the flattening all around the cystitome, which was much more. And this happens if the intralenticular pressure is quite normal. So if you are having, and in 3 dimension, it can be even better experienced by the surgeons. But once you see that, you know that the intralenticular pressure is normal, and then you don't have to do the other maneuvers like doing the intralenticular aspiration, and you can get good CCC even without doing that. But in case the intralenticular pressure is quite high, as you can see in this case, when I'm injecting Viscoat, you can see the pupil is bit dilating mechanically because of the visco. But if you see the anterior capsule carefully, you will find that though it flattens little bit, but then not as much as what happened in the earlier case. So in this case, it is definitely there is an increase in intralenticular pressure. So in such case, I go ahead with my stepwise technique of making the cruciate incisions in the center and then aspirating the intralenticular matter so as to reduce the intralenticular pressure. So once I nick the entry capsule, and I have noted that the entry capsule has not flattened despite injecting the viscoat or Hylucoat, indicating high intralenticular pressure, I start aspirating the intralenticular cortex. And once, because for these cases it is must to avoid any extension of the CCC. So I remove the fluid pockets from all around by aspiration, and then I stroke the peripheral cortex to the center, flattening the entry capsule completely. And once I know that the entry capsule is flat, then I go ahead with the completion of the CCC. So with this sign, I know, and of course you can watch them more carefully in pre-operative period, but this is the intraoperative trick that I use. The third trick I would like to show is in a small pupil. So many times during the surgery or the pre-operatively, the pupil is not dilating, and we get a lot of these pseudo exfoliations in our area. So when you have this non-dilating pupil, putting the toric IOL and later reorienting it in the axis sometimes is quite tough, particularly in old people where there is also senile meiosis. So what I do is that I take a 30 gauge needle and I very gently touch the surface of the lens, very gently, so that it just creates kind of a small scratch mark, which is very fine and visible only at high magnification. And once I do that, this is like an extension of the existing toric marks. Once I do that, these marks help me to easily, orient the IOL once even in the small pupil. As you can see here in this case, the small tiny 2 marks are the ones which are helping me, while the original marks are barely visible. So particularly for very small pupils, this technique has really helped me. Of course, recently Dr. SriGanesh sir has elegantly shown another technique of marking, which is really good. And this is the another thing which I'm doing differently last maybe a year or two, which is I call it like a GPS cataract. We know that markerless systems are there, but they are of course quite expensive. So not every ophthalmic surgeon can afford it. But when I took demo of this system, what I really liked is that it gave me the exact 0-180 degree axis. And it helped me better prepare for the incisions, because I think the incision position makes quite a difference in the post-operative outcome, refractive outcome. So when you have a cornea like this, unmarked, you never know where the 0-180 degree exactly lies, because there are so many different factors like head position of the patient, the microscope rotation or the torsional eye movements, which is going to change the exact axis, 0-180 degree axis. So what I've started recently is that I ask my fellows or my assistant to mark each and every patient at 0 and 180 degree. So, and then once I have these marks, I know exactly where I want to place the incisions. And that has made my surgeries or the refractive outcomes more predictable. So I think even if you don't afford the markerless system, you can easily do that. This is how we do it. I have trained my assistant to just do freehand marking. And with this Android iToric app, which I have developed, we just take a photograph and I know exactly the position of the marks are. So the workflow is not hampered at all, and still we can get away with a very good refractive outcomes. So thank you, Dr. Gaurav, and thank you all. That was a few things which I wanted to share.
Thanks, Sourabh, and Dr. Kumar. Go ahead.
Sourabh, that was an excellent presentation. I like the way you bent the cystitome. But there was one, I don't know whether you've seen that, made by Epsilon, which actually bends the cystitome for you. Have you used that clip? And there was another presentation done by somebody from Chennai, because if it's a deep-seated eye in different sizes, so there are different lengths of needles, different angles of cystitomes, because deep-seated eyes behave very differently, like you rightly presented in your animation. And as you also said about the mark that you did manually, do you see these marks manually post-op? Have you dilated and seen, and whether it'll affect the quality of vision or anything? Of course, it's off the visual axis, it's off the center, the pupil comes down, and that's going to be much beneficial. But is there anything? Otherwise, I thought Sri's idea was brilliant, where he just marks it and then, you know, it remains in the center, but the mark disappears over sometimes. So that's, I don't know if all of you know about it, that Sri has invented something which you actually fold the IOL and it leaves a mark on it. And this mark is there visible for about 5-10 minutes after the surgery, and then it completely disappears. So I would now like to, I'll ask you to comment something, and then everyone in the panel, one by one, I can take over and I can ask them to start commenting on your presentation. So Sourabh, you can say something, and then we can start.
I think Dr. SriGanesh sir's innovation is quite good, elegant, and I'm planning to use that once you know, I get that marker. I think it's brilliant. In my technique, of course, this I've been using for a couple of years. The only issue, as you said, about the, you know, aberration, whether it can cause. But as you said, these pupils are really small, and these are very tiny marks. You know, you can barely see it on slit lamp also with, you know, magnification. And regarding cystitome, again, I think Dr. SriGanesh sir has invented that epsilon bent. If I think he can comment. And as you rightly said, I think every surgeon can make his own, you know, kind of needle. But that idea is brilliant. And I'm thinking that if we can make something which can make a curved kind of cystitome, which because it's difficult to make it, you know, curved with hand. So I think that's one of the.
Thank you, Sourabh. I'll now ask the expert panel. So we can start with Sam. What do you think about the presentation, and what would you like to give a take-home message after this?
Well, first of all, I really enjoyed the presentation. The videos are wonderful. The concepts are excellent. You know, if you go back and respect history, the original capsulorhexis forceps designed by Peter Utrata was straight. And just as you showed in your little video, if you have a straight instrument, it lifts the superior or superficial lip of the incision and flattens out the chamber. So I modified it to be curved, and I think most capsulorhexis forceps are curved today. So again, following the anatomy of the anterior segment is essential. Another comment on the hypermature or the intumescent cataract. In fact, coming from Singapore, I like to call that Prof. Chi has shown that if you have an intumescent lens, you can massage very gently the anterior surface, push fluid out toward the side, and that will flatten out. Once you have a scaphoid anterior capsule, as you indicated, that changes the whole game. A flat rhexis will allow you to make it round. If you have it shaped like this, if it's very, very convex, it will tend to peripheralize. We all know that. So flattening out sometimes even requires, in a very, very shallow chamber and very intumescent cataract, it even requires a very, very small vitrectomy through the pars plana. Just place your trocar, aspirate for no more than 2 seconds. It'll flatten everything out. So sometimes people forget that. And then always the use of mannitol as well. So as you say, so long as you can make the anterior capsule flat, you're going to have not that much trouble with the intumescent cataract. But you have to go through every step in order to get it there, and you have to recognize it, as you indicate, the flattening of the capsule. It's brilliant. That's all I have to say.
Thank you, Sam, so much. Ron, can you take over and give some comments?
Yeah, actually, Sam said much of what I was going to say about the massage of the white cataract, which, as you all know, soon originated. Actually, we put a movie into this year's Oscars Film Festival, and I'm glad that we actually won the best film in that category for handling the white cataract. It's called A Whiter Shade of Pale. And but I think, Sourabh, you showed it very nicely that, just because you decompress a white lens by aspirating, it doesn't mean you flatten the whole dome of the swollen lens, and there are little pockets around, which is the point of doing that massage. But I think you showed that very, very nicely. Thank you very much.
Kumar, can I make a comment?
Yes, Tom.
Yeah, yes, it's an excellent video, Sourabh.
Thank you.
Very nicely, very simply described how to handle a white cataract. We recently published in the JCRS where you can know which intumescent cataract needs to be decompressed see, you can show the pockets on NTS segment OCT, and you have the pockets, and then the pockets are the one which you would need to be handled while decompressing the lenticular space. And with a simple 30 gauge needle, you can aspirate the fluid from these pockets, and the cataract, the intumescent cataract, decompresses very nicely to give you a very safe and round capsular axis, and that virtually classifies your white cataracts into groups having cataracts having spaces, interlenticular spaces, and cataracts do not having spaces, which can be handled very safely and a different way. Thank you.
I think I would just like to add one more thing, Kumar, to it.
Yes.
That you have, and all those who do have intraop OCT microscope, on the table itself, you can see that there are fluid spaces or there are no fluid spaces. So those dark areas can be seen. And if those dark areas are there, that means the fluid is not going to come out. But if there are no dark areas, it's absolutely greenish in color. That means, as soon as you give a nick, the fluid is going to come out. So that is, again, very, you can say, a dynamic way of seeing on the table itself what is going to happen to the white cataract. And I think that was also published in JCRS.
Yes, in fact, Namrata, we have a very nice talk coming up from Ron here. He's going to talk on something similar as well. So let's wait for hearing what he has to share. And I think unless anybody has, because we are running short of time, I think, can we go on? If there's no quick comment from anybody?
Just a couple of comments if there is time.
Yes, Dr. Ramamurthy, sir.
No, one is excellent videos, Sourabh. I mean, just a couple of words. I mean, I've been always doing my Rexis through the side port. Using the through side ports. One side port, a Sinski hook goes in, stabilizes the eyeball, and then the other side port for the Rexis. That gives me good control, but great modifications. Number two is, as far as the Rexis is concerned, apart from the other points that have been mentioned, I always found that when you make the initial nick, if you curve it a little bit instead of leaving it radial, that's when it tends to run off. But if you have curved it a little bit, then make an arc of it, your initial incision, then the tendency for it to run to the periphery is extremely less. I think toric IOLs, all of us have started using it large numbers. I don't understand why the manufacturers don't hear us and make a larger mark. I mean, that would solve the problem. I think they should do something about it. And the last thing about your temporal incision, that was mainly about for toric IOLs or for your normal IOLs?
It was for all cases, like wherever I'm going to plan. So actually that kind of makes us more cognitive about, the effect of incision on the surgery.
For my normal intraocular lenses, I won't bother so much about it today, because all of us know about the centroid value of the, the astigmatism induced by a 2.2 or a 2.4 millimeter incision. So whether it's 5 degrees up or down, it hardly matters. But of course, for toric IOLs, I think it would be a great help.
Thanks, Ramamurthy sir, for those wonderful tips. And I think we'll go on to Ashvin now, because our backend team says that the signal from Dr. Ajoy's laptop is not strong enough for us to stream the video. So we will, wait for some more time till they can fix it up. And so Ashvin, let's go ahead and see. He has two nice pearls to share with us. Please go ahead, and let's all switch off our videos as suggested by Kamal, because it seems that makes a difference. That's what I'm getting to hear from all our team. So while he presents, please switch off, mute ourselves and switch off our videos and let him have the field. Ashwin, we can't hear you. Are you muted?
Yes.
Yes. Sorry, can you hear me?
Perfect. You can start again. Yes, we can hear you now. Go ahead.
Okay. Thank you so much, Gaurav. And my first pearl is going to be on vitrectomy-assisted phacoemulsification. And I think it ties into in line with what Sam was trying to say a little while earlier about, about releasing the pressure. So let's understand what happens in aqueous misdirection. You have an anterior segment and posterior segment. And on a slit lamp, it probably looks pretty decent and nice. But the problem arises when you go in with the BSS during phacoemulsification. This BSS kind of finds its way down into the vitreous cavity, and that probably swells the vitreous body overall. basically causing a shift or positive pressure from behind, and that releases and that gives you a shallow anterior chamber. Let's see this in real time. So you have this small little gap of coloboma there. I've made my incisions. I made a trepan blue entry, and I've also done my rexis. Now, till now, I'm using viscoelastic, so there's no problem as such. And usually, you'll find that in these situations, you'll not find issues when you're having viscoelastic or very minimal amount of fluid. And see the amount of depth I got initially when I pushed it in that viscoelastic. But as and when I'm progressing through this case, along with phacoemulsification with the BSS, and that problem here is the BSS, and the BSS kind of finds its way down. And while I'm going for 3, 4, 5 minutes into probably into the phaco because of the shallow chamber. Now watch this, what happens. The minute I'm pushing in viscoelastic, it does not find its way into the eye. It's instead lobbing out. The reason is the positive pressure from behind. So this is the real problem. And what do? We put visco injection, we put iris hooks and capsule tension ring. Those are not going to solve the major problem of the positive pressure that's from behind. So the real issue over here, and what I started doing a couple of years back, and I thought it really has helped me in a lot of other cases as well, is actually pre-placing a trocar before I even start my phacoemulsification. The reason I pre-place it, you can also do it after starting phaco, which is what I've started to do nowadays. But pre-placing it helps because visualization of the probe is really easy. And then while I'm intermittently using that dry vitrectomy cutter to kind of release that pressure from behind. Now let's watch what happens immediately in that same case, which I just showed you. I'm doing a dry vitrectomy at 1500 cut rate for 7 to 8 seconds or even lesser sometimes, and just see the immense amount of depth I'm getting in this thing. There are loads of advantages to this. I will come to the advantages at the end of my slide in my presentation. But basically what I'm doing is intermittently I can use this as and when I go. The more number of times you use, the lesser number of seconds you must be using. Try not to increase the number of seconds. It really doesn't benefit. It's just 3 to 4 seconds and you're good to go again. So it's a very small trick, but it really has changed the way we do any form of aqueous misdirection problems. And you can do this up until you place an intraocular lens as well. Post that, I always use a single pass photo in these coloboma cases, but I'm not going to show you that because this is not that talk right now, and I wanted to show a different pearl. Now you may be worried about chewing up the bag, and these are some worries that anterior segment surgeons might have, and I think that that's a very valid one. I think you need to take care of not to chew the bag, not to push too much vitreous. But major advantages is it maintains the compartment. It reduces any risk of shallowing of the chamber, which is one of the risks when it comes to corneal endothelial safety. Then your posterior capsule also does not get this thing. You really don't need, prevents your hydration of vitreous and positive pressure and other complications that you can probably find in your other aqueous misdirection syndrome. Thank you for this, Pearl. I'm just going to stop this share and share with you a video that would help me explain this second. Pearl, I would say this is something that I've started to do. It's still work in progress, but it's a product which is already there in the market. I thought it's a very elegant tip where it reduces my phaco time, phaco energy. I've done my femto laser for this one, just the rexis part, and I'm going to use a different form of chopper. So the chopper which I'm going to use is a MyLoop chopper over here, which basically helps me chop this nucleus. It's a pretty dense nucleus, and in order to, I'm just taking off that superior plate from the femto, and once I've done that, I'm ensuring that I'm placing this MyLoop lens, a MyLoop inside the cataract's bag, and once it swings around, you can see that swing behind. Always ensure to keep one edge or one instrument inside the eye on the left, so that holds that nucleus pole, the inferior pole, it holds it down in place, because this has a tendency to swing the whole nucleus. And you'll see this. I'm doing a 4 chop. It's a 4 pi. You can watch this in the second pi, especially over here. Very important to understand, once you snare this all around, it does work like a snare. And you basically have to hold that cataractous piece inside, because watch what happens. See the inferior pole just lifting off and the superior pole going all the way down. Once this is done, you basically have 4 big chunks which can easily be removed from any bag. Why I wanted to show that is because you can do this, and I think the great advantage to this is the IA, irrigation aspiration, is completely is already taken place. You've basically cleaved the whole cortical plane before you've even started the irrigation aspiration. So that really helps in a femto case, and that's as we all know that femto, usually we have this struggle of irrigation aspiration, as everything has changed, the whole dynamics of how irrigation aspiration in femto cases are. So that's my few little pearls, and I just wanted to show you guys at the end of this case. I've placed my lens. I do use a Wong incision nowadays, and this is a post-operative day 1 of the same patient. Thank you very much. These are my 2 pearls which I wanted to share with you guys.
Thanks, Ashvin, for those really nice 2 pearls. And here I'll look for Dr. Mahipal Sachdev if he's here. Would you like to comment on the vitrectomy-assisted cataract surgery? It does seem to become more popular by the day. So you have been using that in some cases as well, sir.
Yes, I'll wish to comment on both his tips that are there. The first one that we really call it as the third hand, which we started popularizing a couple of years ago. Now, whenever you are using collobomatous eye, a small eye, nanophthalmic eyes, or maybe even phacoemulsified glaucoma, the only difference that I have from Ashvin is that I don't take in the vitrectomy probe to do the cutting there, because you really don't know. It's a fluid misdirection. If at all it is there, then the fluid actually comes out from the trocar. So you can actually go in and allow the fluid, and all you need to do is whatever is coming out, you just do take that, because often the cataracts are mature. So if you are actually going in, it becomes a totally total procedure where it's a blind procedure. So you could injure the backside of the capsule, but it is really a fantastic procedure. Whenever there is fluid, there is an increase in the pressure. Typically, we have shown in phacoemulsified glaucomas, etc. So it works wonderfully, and you can do it intermittently. And at that particular time, also, you don't have infusion on throughout the procedure. And there's a good, if you have decompressed the posterior chamber and back of the lens falls down, and you can easily do the procedure. So that is something which is a very, very good tip, and it is not it is something that we should do it pre-planned. It is not at that particular time, because the eyes where you are expecting an upthrust, you can do it as a pre-planned procedure, and it really helps. Now, regarding the second thing, my loop is made of nitropolol, and it is the same material that you have for the rexes that is being used for the Zepto. So this material cuts very, very hard cataracts also. I don't know why he wanted to do a capsulotomy with a Zepto. So you can do a normal capsulotomy. A capsulotomy with a Femto. You can do a normal thing. The only thing what he rightly said is that you have to put the nucleus down with the second hand, and you don't have to allow it to come up. And it can really, the advantages in really hard cataracts, we did some videos, SriGanesh also has videos, so it really cuts very well. It does give you a fright, because you have to take it below the nucleus, and at times it seems that it is going to rupture the posterior capsule, but it never, because the material with which it is made is very, very flexible. So it does not, in what we have done about 25-30 cases, there has never been a problem as regards the rupture of the posterior capsule. So I think it is a good stuff to actually cut the nuclei and reduce it to as many sizes as you want. You need not actually take it out. You can close it, and then you can rotate it, and then again you can open and cut it. So, but as you work 10-15 cases, you get a lot of comfort and a lot of experience. So I think the my loop from Zeiss is also a very good technique to do that. So both his techniques are good, and both are good pearls, and whatever little differences we have from what he does, I've told you.
Thanks, Dr. Mahipal. Dr. Kudlu, would you like to add anything to what Dr. Mahipal said? And quickly, let's have quick comments from our panelists, and then we'll go on. So anything you would like to add, Dr. Krishna Prasad?
A nice video, Ashvin. Just my one comment about the my loop. I've seen him actually after cutting the 2 pieces. He has removed the my loop. Then he filled the chamber with the viscoelastic. Then he turned the nucleus. Once again, he cut into the 4 pieces. One of our panelists, Dr. SriGanesh, is also around here. He does it in the one shot. One shot means once you go with the my loop inside, cut into 2 halves, then once again he rotates. So my question to all the panelists, whether you have to do in a 2-step my loop or single step my loop, do you have any advantage by doing single step or 2-step my loop?
So who amongst our panelists also uses the my loop? Is
yeah,
there
I've used
John
it.
or Ron? I know Ganesh you're using. I'm going to keep you for the last. Ron, do you use the? Have you used my loop?
No, I've tried it out. I have to say that, if I'm going to do a femtosecond laser capsulorhexis, I might as well use the femtosecond laser to do the softening and do it. So no, I don't routinely use the my loop.
And if anybody else doesn't use, then we have SriGanesh who has been doing this for some time. So yes, Ganesh, your quick pulse, yes.
Yeah, basically the chamber has to be maintained. So if the chamber shallows, then it's better to remove it after the first cut, put in viscoelastic, and then again insert it. But you can do it in one step if you have a good chamber maintenance and the visco has not leaked. Most important is you have to have a very good hydrodissection, and the nucleus should be stable. So that is important. So if you have a good hydrodissection, then it's quite nice and quite easy to
There
use.
is a question, Gaurav, which says, which is directed to Mahipal, that if you have a choice, you have the my loop and you have the femto. So would you like to break down the femto with, would you like to break down the hard cataract with the femto, or would you like to use a my loop today? Since you have both the technologies, what would you prefer and why?
So I would definitely prefer a femto. It was a question of seeing whether it works or not. So I think this is a poor man's femto. But you can actually do both. In the femto also, you can have the cut, and then if you have any problem, you can do it. I have actually tried cutting a beetle nut with it. The only thing that I cut was a beetle nut, XYO I'm talking. But if you have an almond or a peanut, it cuts it very well. So basically, it does have a lot of thing, and it's not still commercially available. So we just got a couple of samples. So as what SriGanesh also said and what Ashvin is showing, it depends on your comfort level. As you keep on increasing the comfort level, I think as the comfort level keeps on increasing, I'll be able to give more details once it's commercially available, maybe in a year.
It is commercially available, my part. It's commercially available. It was launched.
So Dr. Ganesh, how much is it costing to us? Yeah,
I think it's about 12,000. It is a single-use disposable. It's single-use
12,000?
disposable.
Yeah.
About 12,000.
Well, combining it with femto will make it outrageous. I think, outrageously expensive.
But the thing is, we actually did a study and we found that with femto, you reduce in hard cataracts, grade 4 and above, you reduce the phacoenergy by about 30%. But with this, it's more than 50%.
So I would then suggest using this alone rather than combining it with femto. If you had to, like, financial sense would be better. All the same, I think we got the message. Namrata, a quick word and then we go on.
Combining it with femto doesn't make sense. If you're doing a femto rhexis, then you might as well do a femto cataract too, like Ron said, and you can use it alone. And the other
at least not financial sense for sure, Namrata. Yeah, thanks. So I think we have good messages. Yes, Dr. Ramamurthy.
Just a basic question for Ashwin. I mean, great presentation, Ashwin. But in a congenital coloboma, is it necessary to suture? I mean, you guys have been teaching the world about iris suturing, but the patient has lived with it long enough. You did say that that's not the main emphasis on your video, but I mean, the rhexis is going to opacify. Is it necessary to suture it?
So we've done quite a few number of these, and I think predominantly most of them have come out to be very, very happy with the suture. Honestly, I mean, I know the contrary thought to this, and we've done enough and more, and nowadays it's become a standard routine where we've got very good results from actually suturing.
You mean the glare goes down or the quality of vision improves?
It depends on the retina and how the case from behind also is. If it's involving some other part, then I am not able to comment too much on that. But definitely in the normal retina cases, it's immensely.
So it should be macula sparing.
Yeah, it has to be. Yeah, it has to be those.
Because you don't know from where the patient is fixing.
Right.
Yeah, I agree. That's a great point, Dr. Ramamurthy and Ashvin. So I think we'll quickly go on. I think Kendall is ready with the presentation. We have a video at the back end, so I'll request Dr. Kendall to please start. She has some nice pearls in COVID times, how to be tackling intumescent cataracts, and when not in COVID times as well. So I think that'll be an interesting way to see how she manages. So back end team, can you please play her video while she speaks from the US? So technology is helping us do so much.
Yes, thank you so much, Gaurav. Jazz Wonder is going to help me play my video from there, but hopefully it'll be a little smoother than when I play from here. So, okay, perfect. So I will be discussing white cataracts, which seems to be a very popular topic today. It's been discussed pretty thoroughly, and I think we've really hit on a lot of the main points. These are my disclosures. So of course, we all fear, you can advance, please. We all fear the things we talked about, the increased intralenticular pressure causing the capsulotomy to radialize here. You know, of course, the integrity of the capsule is not normal in these cases. It's just so friable. It has a tendency to go out. And I think we've talked about this pretty extensively. You know, so I really like to use the femtosecond laser for these cases. This is a case I did quite a while ago where you can see that fibrosis of the anterior capsule. And you see in less than a second, the femtosecond laser allows us to penetrate that capsule very easily to avoid radialization. Now, of course, it's a different point in time now with the COVID crisis, so we're not allowed to use the femtosecond laser. In fact, we haven't been allowed to even do cataracts. This is just a few pictures of my staff right now in the midst of the COVID crisis, but we haven't been able to use the femtosecond laser in 2 months now. And actually, we just went back to cataract surgery this past Monday. So I've only done a couple cataracts since we've been back. It's been 2 months really since we've been able to do routine cataracts. We've been just doing emergency cases, mostly corneal cases. So I actually had a white cataract this Monday because we prioritized our patients that have very, very poor vision or are legally blind. And this is a gentleman who has a history of a bilateral lung transplant, CMV retinitis, and he had a hand motion white cataract. So I'd like to share this without the femtosecond laser. Let's see, it's still a little poppy, but again, you can see issues with the capsulotomy, the increased intralenticular pressure. We want to err on the side of making a very small capsulotomy in these cases. We've talked about looking for that plume because a lot of times these lenses are partially fluid, and they can certainly cause the capsulotomy to radialize. I don't want to repeat too much of what everyone else has said, but I really like some of Ash's pearls about decreasing the posterior pressure. That's one of the biggest dangers in these patients, especially if they're blocked. Sometimes we do have to do a little vitrectomy, so that was a perfect example with his coloboma case. But these lenses tend to be pretty soft, and so we're pretty easily able to remove these lenses pretty quickly with very small amounts of energy. So the capsulotomy comes out okay. So again, high molecular weight viscoelastic like Helon GV or Helon 5 is helpful. I think a lot of the other helpful hints have been reviewed already. And again, the vitrectomy. So one other thing that I'm going to show in just a second, you'll see this took about 30 seconds to remove this cataract, mostly with aspiration here. But I would have to say it's been a while since I did a white cataract without the femtosecond laser, so I think we've become pretty spoiled. I know Ron had commented that he prefers the femtosecond laser too, just to avoid that possibility of radialization and not have to worry about aspirating that fluid material. But another thing that I really like when I'm doing the IA is the transformer, which allows us to switch from either a coaxial to a bimanual irrigation aspiration. So here we're doing coaxial irrigation aspiration. And then in order to get that subincisional cortex, I like to switch to bimanual with the transformer. So it's a really nice feature with the transformer from Alcon. So here I'm going to use the bimanual and get that subincisional cortex pretty easily. A lot of times times white cataracts can be associated with a lot of other problems. This wasn't a traumatic cataract, but as Ash showed us, the colobomas, the traumatic cataracts, possibly a zonulopathy, these guys are abnormal. Anytime your capsule material is abnormal, you just go ahead and flip forward from there so we can get rid of the music. It's so choppy. But, I think we've reviewed this in 3 presentations this morning, but I really do prefer the femto laser. I think it reduces the risks, but all of these nice pearls as far as decompression, both the intralenticular pressure as well as the posterior pressure are really, really key for keeping this a very safe surgery. So I don't know if there's much more to cover with the white cataract, but I think it's one of those things that we all fear. It's one of those universal problems that we have with cataract surgery. So we all get a little more nervous. I like to put these cases at the end of my day, typically, if they can be unpredictable. Certainly if I'm sure they have a zonulopathy, or if I might need to do a pars plana vitrectomy, I'll try to put them later in the day so I have more time with these patients. So,
thanks, Kendall. I think wonderful presentation, and I'm happy to see that you share. Many of us who use femto-assisted cataract surgery, that our favorite way of doing these cataracts is with the femtosecond laser, in fact. And what about those occasional cases where when there's a very big intumescence and then suddenly there is that fluid gush as soon as the capsulotomy breaks through, and you may sometimes have a tag? So how do you kind of you did show excellent tips, but specifically, would you like to say something how you would want to address? Dr. Kamal, can you avoid sharing your screen for now for a moment, please?
Oh, sorry.
I'll invite you to share the screen once we are ready.
So I say,
I accidentally.
Certainly, if you can see that convexity to the anterior capsule, you can just do a needle puncture and decompress in that way. That way, you're less likely to have a radial extension, and you can even just aspirate that material, even with the needle. At that point, would be a good idea. That can prevent radialization. Again, Little's technique, which I was using there, where I was just kind of pulling the capsulotomy straight back toward the center, as opposed to try and guide it around in a circle, just pulling it straight back to the center. So Little's technique is very important in these cases as well. And making sure that you try to make your capsulotomy as small as possible, because it'll always end up being bigger than you expect.
I meant with the laser, like when you're doing a laser-assisted capsulotomy, and sometimes 90% of the times you will get a perfect all the way through. And are there any tips, like suppose you're not sure, and then you have that gush of milky fluid when the laser just breaks through, and you have that mushroom thing coming up, and then you're not 100% sure that in some of these capsules you may have tags and you won't see them so well. So how do you plan for those?
Well, certainly the trypan blue helps. But we have several femtosecond lasers, and my favorite for the white cataract is the Catalyst laser, because it allows us to do that capsulotomy in about 0.8 seconds. Some of the other laser platforms, it does take about 7 seconds, for some of them, up to 7 seconds, I'd say, for some capsulotomies. So there are some femtosecond laser platforms that are not as ideal for white cataract as the Catalyst, I would say, is the best one for this, because it just has the quickest capsulotomy. But always staying with trypan blue, which can help illustrate, it can really show you a little tear if there's a weakness there. So you can then try to, you might even need to use scissors to take this capsule around if it's really heading outward. So I would consider doing that. Again, luckily these cataracts are pretty soft for the most part, so you can really aspirate them primarily without having to manipulate the lens very much. So that's fortunate, which puts less and less stress on the capsule.
Wonderful. I think Ron has some excellent presentations, and I was going to ask you, Ron.
Yeah, very nice, Kendall. I think I have 2 little points to make. One is, I think if you suspect that there's a tag, I think when you're doing IA, it's very important to do your IA away from the edge of the CCC, so you don't pick up one of those snags. That's number one. Number two, you mentioned, Kendall, that most of these have soft cataracts. But in my movie, I said that white cataracts are like a box of chocolates, like Forrest Gump used to say. You never know what's inside a white cataract. If you get the white brittle ones, great, you're really happy. But sometimes you get Morganians, sometimes you get a really rock hard cataract. So I think that it's like a hidden treasure. You don't really know what you're going to get, but it's nice you get a soft one.
I agree, Ron, but I think some of this we can gain from just the patient's history. So in this particular patient, his cataract developed pretty rapidly. As I mentioned, he's immunosuppressed. He has CMV retinitis, and this cataract really developed over a period of less than a year. So I knew it wasn't going to be super hard. So, and also a traumatic cataract, if it's within a year of the initial trauma, it's going to be a softer lens. Certainly if it's a 90-year-old patient with a white cataract, I would expect it to be denser. So yeah, I think the history can tell us a lot about what to expect. But you're right, Ron. It could just, anything can happen, of course.
So let's hear Dr. Masket's. See, I was going to ask Sam what he thinks about this.
Yeah, I think Kendall touched on something that may unfortunately not have been, the highlight of the presentation. Was very important, was the choice of OVD. So if you have, as an example, a tag and you're not sure, one thing that after you put in the trypan blue, anytime you remove the anterior capsule in a femto case, always bring the capsule toward the center of the chamber. If you do have a tag, it'll come with you toward the center, it won't peripheralize. If you take the capsule, as we typically do, and just pull toward us, a tag can peripheralize. But if you have something where you suspect there is a tag and or it's tending to radialize, OVD is very important. You want to place a highly retentive, you want to use a dense, cohesive, not a dispersive agent, and you want to place it peripheral to the tag, not central. If you put it central, you will cause it to extend more radially. If you put it peripherally, you will keep it from extending. So dense, cohesive OVD is important, and Kendall touched on it.
Wonderful. Thanks for those pearls, Dr. Masket, and that's great advice. I think, okay, one quick question before we move on to the next one. I know that most of our panelists and speakers here are using femtosecond laser. Now, is there anybody on our panel or from amongst our speakers who feels that femtosecond laser is not really required for intumescent cataracts, or not really a great one? Let's hear it.
Femtosecond is a great boon for white cataracts.
Yes, whether it's not. So I think Dr. Dhami raises his hand. Let's hear it from him, because all of us are probably convinced that femtosecond is the way to go for intumescent. Dr. Dhami, let's hear from you.
See, Gaurav, Dr. Namrata really said that you have an intraoperative OCT on a microscope. You see those spaces in the intumescent cataract, which really create the vacuum and the pressure into it, into the capsular bag. If an anterior segment OCT is done preoperatively, you have a very planned surgery. You go into the OT and merely putting a good viscoelastic and aspirating with a 30 gauge needle, displacing those spaces, you get a very good normal cataract. And virtually even the density of the nucleus can be assigned on an anterior segment OCT, whether you're going to have a soft cataract or you're going to have a real dense or a real hard cataract to be manipulated. I think you can very well do in intumescent cataract without femtosecond laser to be there.
So what I do normally is do a femtosecond and shift the patient to intraop OCT and then do, on the intraop OCT. So use both of them together. So that kind of helps.
We preoperatively. Our cataracts are assigned that they are going to be needle aspirated or not. So we are well planned and prepared for it.
Dr. Dhami, the only thing is it is a comparison between a closed chamber capsulotomy versus versus where you have made an incision. So if you have to do, whether you are using an OCT or not, that is going to be immaterial, because you have to enter the chamber. While you are doing a femto, there is no opening of the chamber, and therefore the intralenticular pressure cannot cause the problem. The only thing is that we always use trypan blue, because as Gaurav was saying, there could be leakage of the fluid which could obscure the cutting of the capsule at a particular point, and you could change the default setting in the capsulotomy that you want, so that even if there is slight decompression with fluid coming out, it can still have a larger default and do that. And the energy settings for the capsulotomy could be increased. So these are a couple of tips that we do in femto, but for phacoemulsified glaucoma, shallow chambers and intumescent cataracts, beyond doubt, when you are working on a closed chamber, this will give you strong advantages over entering the chamber and then trying to do a capsulotomy.
Gaurav, just one comment. I use actually both femto and manual. So what I do is I make a 3 mm paracentral capsulorhexis. Because in an intumescent cataract, the maximum pressure is in the center. And if you're trying to make a larger axis, it takes more time. And it is quite thin in the center, and then you can have tags, or you can even have a runoff, even with a femto, in a very intumescent cataract. So if you make a very small rhexis in the mid-peripheral aspect, then you can, the chance of running off is extremely low, and then you can aspirate the fluid, and then you can do a secondary rhexis. And with this way, you hardly have any Argentinian flag sign. So this is something which can be done.
Nice thing for Kamal Kapur waiting to see.
Yes, so I think let's go on. We have lots of interesting stuff to come up, and Dr. Kamal has some amazing improvisations that he uses in his practice for his cataract surgery. He's a prolific surgeon. Kamal, let's go ahead, see what you have to share with us.
Can you hear me?
Yes.
Okay.
But
so I have some videos.
You have to check your screen.
Okay. Is it better now?
Yes.
Yeah.
Okay. So I guess today is raining white cataracts like a thunderstorm. And guess what am I going to talk about?
White cataracts.
I probably would agree with all the previous speakers, but also would disagree. And I will show in my presentation this innovative technique of the inverted T, which I started many years ago. And now I perfected it to manage practically any situation in the anterior capsular rhexis. And it saves the day. So you could even have an intumescent cataract, Mogagian, phacoemulsific, phacolytic cataract. This inverted T does save the situation. It's a very meticulous procedure. If you follow it to the dot, for last probably more than 500, 600 cases of white hypermature cataracts, we've never had an Argentinian sign. So I'll just go to that. People might object the way I'm wearing the mask here in the COVID era, but this photograph has been taken long back ago, so I should be excused for that. Because this is not the way to wear a mask in the theater. So you could have a situation like this, a phacoemulsific glaucoma, you can see it's a steamy cornea. You could have an Argentinian impending sign. We can see the liquid oozing out. You could have a tear about to happen. You could have a peripheral extension going in a hypermature cataract. You could have a traumatic cataract with a complete tear of the capsule. Or you could have the Argentinian sign itself. So I probably will be talking about this technology or this technique which I've evolved over time. I call it the inverted T. There are no financial disclosures here, but yes, I think I need to wear the mask now. So I'm wearing the mask now. So I'll just give you a run through a brief animation. How did the inverted T come into action? So all you need to do is make sure you put in the trypan blue, you dilate the pupil, you stain the cataract. I start with a very small incision, just enough for my needle to go in. Then I put in more viscoelastic, I flatten the cornea, and then I use a bent 26 gauge needle with a bevel downwards. I make a linear movement, I create a straight cut. Once I create that cut, I push in more viscoelastic, which gets some fluid out of this linear cut. Then I enlarge my incision, and then I use a Vanna's forceps. The video is not visible?
No.
Video is stuck.
Video is not playing.
Patch in between that.
Frozen. Can you try to play it again?
Just click the
video is not running.
It was not.
The video is not running.
It started running just now. Yeah. Okay.
It's running now.
Just play it again.
Is it running now?
Not yet. No. There's a black screen right in the middle, which is not allowing it to run, I think.
What's
wrong? You play the presentation without selecting that option optimize screen share.
Yeah, is it working now?
Yes. Now it's working. Yes.
So I've stained the cornea, I've stained the trypan blue, put in viscoelastic, then go with a 26 gauge needle, bevel bent downwards. I make a linear movement, create a straight cut. While I do that, I also aspirate the fluid in the same movement. I put viscoelastic to flatten the anterior capsule. Then I enlarge my incision because I've decompressed the cataract. I use a Vanna's to create a T. Now this T has two flaps. I use a bent cystotome or a capsule rhexis forceps. whatever I'm comfortable with to complete the rexes. So I'll now go and show, I think the optimization thing is not visible. That's why I'm having this problem. Now let's see another video. I'll play this video and we will see, yeah, this one. So this is a case where there's an intumescent cataract. Can you see the video?
No.
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 It's not playing.
Now it should. Is it playing?
Yes.
Okay, so I'll go to the start. As described by the previous speakers, I make a very small incision, then I flatten the capsule, make sure that the capsule is flattened. The end sign is posterior movement of the iris diaphragm. I bevel downwards, I bend the needle by 70 degrees. I have half cc fluid in the 2 cc syringe. While going in with my needle, I make side-to-side movement so that I don't go to the tissue. At the junction of central 2/3 and peripheral 1/3, I make one stab incision, and in one incision, I aspirate the fluid in a swift, jerky motion. And once I've done that, as you can see that the whole fluid has been sucked out, now the tear will not extend. It has to be done in one movement. Now, once this is done, I push in viscoelastic to flatten and get any amount of fluid which is still remaining in the bag. Now I enlarge my incision. I go in with a straight 1/2 forceps and see what I do. I hold it perpendicularly. I create a cut in between. And this creates a T for me. Now this T is one of the easiest things for you to manage. You have 2 flaps. You have decompressed capsule. Now you can make any kind of rexes you want, any shape you want, any size you want. You will never go wrong because you aspirated the fluid out and then you push viscoelastic behind that puncture and got the fluid out from the leak. And you can see how beautifully you can do whatever, the rexes will not go out. I will hold the rexes again from the other side. Now this is entirely up to the surgeon. He wants to do it in one go or he wants to use the rexes to join the other edge. Now while doing that, you can make a smaller rexes or you can make a larger rexes. And as my bag is decompressed, my rexes is not going anywhere. And we've done more than 600 cases with this particular technique and it has never failed us. So I'll now go for another video. Okay, now I show you another video, which is something similar, but this case is an intumescent phacoemulsification glaucoma, and see what happens. This is a hypermature cataract. Can you see the video?
Yes, it was coming on.
It was on.
Okay, is it coming now?
Yes.
Yes.
Okay, you can see it's a steamy white cornea. The cataract capsule is bulging into the anterior chamber. Side to side movement, one plunge, and then the same plunge I aspirate. I have half cc of BSS in my syringe to support me to suck it out. I make a linear cut. Again, I have a beautiful T, but as we all will notice, the tear doesn't extend. I push in viscoelastic to get any amount of fluid which is remaining in. Again, I hold the edge. Now, mind you, friends, this was a patient with 40 millimeter of mercury pressure. We just gave mannitol, and this is the procedure we did. The whole thing is done in a very, very controlled manner. You can have an oval rexes, you can have a round rexes, any size of rexes you want, because the capsule has been totally decompressed and you have 2 flaps to manage. In case one starts going out, the second one comes to your rescue. Now I'll go to another video. Now we've seen this, now we see another one. Now this is just managing the white cataracts. Now what if you have a white cataract, you've done all the steps and your rexis has gone out and you're called in the theater? Can you see the slides?
Yes.
Yes.
Okay. Now this is a case which was being operated by one of my associate surgeons, and he started to do this, and midway I was in another theater, he called me. As we all can see that the rexis has gone out. Now the inverted T technique will come to the rescue here again. I will just jump to the video. I need to do this jugglery because these are high resolution videos, and so I do the same thing. Even if I don't have a fluid to be aspirated, I created a linear cut with my needle with the bevel downwards, and see what I do. I give a cut in the center with a 1/2 forceps. I get 2 beautiful flaps on the side. So whatever complications which I could think of in an interior capsule situation, I have modified this technique for this year to manage all my situations. And there you have a beautiful capsular rhexis. Now what
excellent, excellent, Kamal. Yeah. So I think, Kumar, would you like to go ahead?
No, no, there are 3 more videos.
Oh, you have? Okay, okay, okay. I'm sorry. Yeah.
Okay, I think I'll jump the videos because I think, now this is again a similar situation. Can we see a peripheral extension here?
Yeah.
Can we see a peripheral extension here? If you want, I can run the video, but I've done the same.
Let's have one more good video. Yeah.
No, no, there are 2 more, but
okay, okay, go ahead. Yeah.
Now this is what I do. I went in, I punctured it with a needle. Here, since the surgery was midway, I didn't have the time.
Can't see the video. It's not running.
Okay,
it's not playing.
I'll just get it back. There, is it back?
Yes.
So this is a peripheral extension. This case was not expected to go out. The patient moved while doing the rhexis. The rhexis went out. So I don't need to put a trypan blue here. I just use the same technique of puncturing the capsule, making a linear cut, using the vanas. I'll jump the video. Using the vanas, making a T, and I'm jumping the video. They're joining the 2 junctions. And there, I have a rhexis.
It's not playing, Kamal.
Yeah.
It's not playing.
It's coming and going.
Is it playing now?
No, we can't see anything.
No, it's not playing. Okay, now we have some view. Just play. Okay, yeah, it's playing. Yeah, go ahead.
So this is a peripheral extension. I punctured it with a needle. This was a normal case. This was not a phacoemulsification or a mature cataract. The patient moved, rhexis went out. So I make a linear cut. I use my vanas. I flatten the capsule.
Again, not playing.
Is it playing now?
It's working slowly now. If you can just let it play. Yeah.
Okay, so I made the linear cut. I use my capsular rhexis forceps. I have 2 flaps. I don't know whether they are visible to you on an internet streaming video, but there you can see me join one loose end to the periphery. And there I will use now the same maneuver on the opposite side to complete the rhexis, and I am back in game. My peripheral extension, which was going beyond my view, I've got it back into my fold and uses the inverted T technique to convert the whole capsule rhexis situation down to my advantage. I've created a bigger capsule rhexis in this because I have a peripheral extension. I don't want much forces to be in the bag. So this is what I did for this particular case.
Wonderful. Thanks, Kamal. And would you have
one more last video?
Okay, let's do it quickly. Yeah.
I have this one video, which is what if you already had an Argentinian sign. This is an impending Argentinian sign. I think I'll skip it. I've already had an Argentinian flag sign, and I'll just play the video. If it's not playing, there it is playing. Can you see that?
Yes.
Okay, so this was I was called in the theater by one of my fellow associates. So there was an attempt to cut the capsule, but the moment I entered, I've edited the video. I realized cutting the capsule will not help. I do the same maneuver. I go within the extension and suck out the protruding fluid. You can see I've decompressed the cataract. Now I've created a linear cut. I went within the Argentinian tear. Through the linear cut, I give my same T technique. Now I have a flap, which is an inverted T or a straight T. I put on viscoelastic, invert the flaps, and all I need to do is join these flaps together. And the other edge, which is on the other side, now since the pressure has gone down, it is very safe for me to proceed and tear the initial cut which has been torn by my fellow associate and complete the rhexis. In case we had proceeded with tearing this particular step, which I am doing now, without decompressing an inverted T, we could have had a further extension. So this is also beautifully managed. So Gaurav, I have one more, but I'll skip that.
Okay, thanks, Kamal. I think that looks good. Let me just bring back my Zoom. Yes, there it is. So thanks, Kamal. Kumar, you take it ahead. Yeah.
Kamal, excellent presentation. I have seen this before. Only one question that has popped up is that when you want to put a vanas to make your inverted tree, you need a larger incision. So again, when you're losing your anterior chamber, so again, that's going to be against you. Another point was you have to know the distance from which you're making your puncture to make a 5 millimeter rhexis or a 5.2 millimeter rhexis. So do you have control on the size of the rhexis with this technique? Will you be able to manage that? And do you have a different vanas, which is easier to put instead of the normal vanas that we see that is going through a larger incision?
Okay, 3 questions, Kumar. First question was that once I've decompressed the capsule, I've sucked out the fluid, then I go in with the viscoelastic behind the puncture. So as I push my viscoelastic, it pushes more fluid out. So my capsule is totally decompressed now. Only after I've done the step, I enlarge the incision. I need to enlarge the incision because I need to use a vanas which works vertically. So I need a bigger incision. So I go to a 2.8 or a 2.4. Number 1. Number 2, I use an angulated vanas, a standard angulated vanas. I don't want to name the company, but I think we all know the famous Bombay friend of ours. We used vanas from there. Number 3, your third question was, how do I plan the site of the puncture? First thing is, I've over time, hundreds of surgeries, I realized, if I go central with the puncture, the tendency for it to run through even in the puncture is very high. But the more peripheral I go, it doesn't tear. And now everybody in my team, Gaurav, is using this technique. So you don't need to be a fancy high-flying surgeon. All you need to do is the junction between the central 2/3 and the peripheral 1/3. This is approximately 2 to 2.5 millimeter from the center. So if you puncture here and you rotate, you have an approximate 5 to 5.5 millimeter rhexis. And since you have 2 flaps in your hand, you can make any size of rhexis you want. You can make a smaller one and you can larger one since you have 2 flaps in your hand.
I think it was an excellent technique, Kamal. The only thing I was worried about was that you were using the main incision for all your maneuvers, even with the forceps, like the rhexis forceps. I would have preferred to go from the side port using a micro rhexis forceps. Yes, Kamal. And then I'll request Dr. Ramamurthy to ask this question.
Again, Gaurav, I used to do this from the side port first, but over time, once I realized I've made a puncture, and once I push viscoelastic behind the puncture, and as the viscoelastic comes out, it practically pushes out 70-80% of the fluid from within the bag. Because I've made a puncture near my wound, I push viscoelastic behind the puncture, and I dip my wound, I let viscoelastic come out. And as the viscoelastic is coming out, it is doing a steamroller effect on my capsule and tends to get out most of the fluid. And after that, you can actually leave the wound open, it will not go to periphery. I've tried in hundreds of cases.
I think great concept, Kamal, and beautifully demonstrated with so many videos. But I think all of us are following the same principles in the sense that, whenever the intralenticular pressure is high, it always radializes. It runs towards the clock hours. It never runs out circumferentially. So what you have done is to your initial incision is not in the radial direction, but it's in the along the arc. And that's the reason that you are getting a stability. And that's the concept of making a mini rhexis. So you have a round opening, not a radial opening. And then you go ahead with this. This is one more variation of this. So the point I want to, there have been so many variations, each surgeon will come up with one. But I think the basic concept remains that as far as your edges of the initial nick that you create is not radially directed, but is somewhat in an arcuate fashion, or in your case, in a circumferential fashion, the tendency for the rhexis to run off to the periphery is minimized. You can fill in with a high molecular weight viscoelastic, decompress the bag and complete the surgery. Yours is one other variation which seems to work extremely well with your hands. But as others voiced it, I would only be wary of doing all these maneuvers with through a large incision, central incision. But obviously, you have mastered it.
Thank you, Rama. I think Ajay, you are ready. Are you having a better connection now? Can you take over? Excellent. So you can share the screen now. Thank you, Kamal.
So, I think we have a few seconds more because there was a power failure at the back end. I just got informed. So our relay was, suffering a little bit. It's on now. So we'll have, before, we go on with the next presentation, which Dr. Ajoy Paul will be sharing his video. I just thought that we can have our panelists chip in with any 1 or 2 pearls so that we can then go on to the next presentation.
On white cataract?
Yes, on Kamal's technique, yes.
I think Kamal showed great videos and the technique seems to work very well, at least in his hands. And each of us has a different technique. And like many of the other panelists also said, I would also be doing the maneuvering through the side port and use a micro scissors or use even a ILM scissors to make those cuts into the capsulorhexis rather than go through the main wound. And whatever you may say, I think all depends on what the consistency of the cataract is and what the intralenticular pressure is. Sometimes you take all the precautions and everything, especially when you're doing it manually, and it just goes into a triple radiate kind of a extension also.
Hello.
So everything, yeah. So it all depends on what lies underneath the capsule, what is the consistency, whether it's a soft cataract, hard cataract, and like Ron said, I completely agree with him. What you will find inside, you will only know after you do the rexes. It can, vary in any manner.
Thanks, Namrata. Ron wants to chip in and then we go.
Yeah, and when they are hard, it can be a real problem if they have extended, because that's where your expertise is going to be required. If it's a soft, you can still aspirate. That's not a big deal.
I think the pressure dynamics have to be understood, if I'm permitted to speak.
So?
Yes.
Yeah. Can you hear me?
Yes.
Yes, Rohit.
Oh, yes.
Yeah.
Yes, Dr.
Because by all means, the chamber, the pressure in the interior chamber has to be equal or more than the intralenticular pressure by all means. So that is the first thing. And there should not be a sudden decrease of pressure. So a calibrated main incision or the side port incision through which you have to go is very important. Then as you have to give it a direction, that is number 2, which has already been well pointed out. And the most important thing is that by all means, you have to take into consideration that the other parts do have a raised intralenticular pressure. So that has to be taken care of. And we have to realize, and these intumescent cataracts, at times you have the interior compartment and the posterior compartment. And that posterior compartment is also at times pushing it from behind. So you have to neutralize that posterior compartment also by all means.
Thanks, Dr. Rohit. I think we are streaming nice and clear. I'll request Dr. Ajoy to go ahead. We had to interrupt his presentation because of a break in internet when he was presenting, and our backend team is ready to stream his video. Please go ahead, Ajoy.
Okay. Thank you. Yeah, I think we start with this subluxated cataract. And this has been a challenge. Basically, we do manual capsulorhexis the way we have been doing, get it away from the rhexis area, and then gradually we get in with the hooks and rings. And this is also a challenge as we've been doing these challenging cases. The railway technique of putting those CT segments and CTRs, as you can see, we have definitely had agonies with capsulorhexis. More than once we have had to abandon the case because the rhexis has extended. Now this is a challenge. The cumbersome CT segment, the 9
There's the audio.
And then we have those railway technique. Maybe most of the audio. Can you hear me?
Yeah,
hello?
continue.
Yeah. So we have those flags and yes, in subluxated cataract, intrascleral fixation. As you can see, the flags, we can position the I think the video is moving. Okay, the rhexis as we want. The video is not moving. Yeah, that's it. So here we have the capsulorhexis, as we have seen. This is the rhexis is done, and we are doing the rhexis forceps. Just snap it and take it off so easily. It comes off. So we have got this right distance from the periphery, and we can do some. As you can see, the next step, see the rhexis margin is so clear, and we have decided to go in for Sioni, but then again we are going for the CTR. Now this is something I would always prefer going before the first step, as I do, because I need a horizontal support to my and then put the hooks, the capsular hooks to support my bag and get a the vertical support, and do the bimanual removal of the cortex. This was a young lady of around 43 with Marfan. She had actually come for a refractive surgery, but then we have seen this is a Marfan's. As you can see, the bimanual removal. And stages, chamber is filled, and then as you can see, the bimanual removal of the capsule. And the lens we prefer in 2020 is definitely the lens which has changed the way. This is a monofocal lens, but it has got the eye-hands lens, which has got a intermediate visions. In these situations, definitely, as you can see, we can just maneuver it, put it in the bag, and the lens goes in. But, and then I use a trocker, a MVR blade, 23 gauge MVR blade. And then this is the innovation that we are doing. This is a iris. See, I just push in the CT segment and then try to put it there in the position. And this is the innovation that we are doing, avoiding those sutures, and hold it by a forceps here. And then the bimanual way, put it on the other end, and then just pull it out. I thank Dr. Amar and the whole team of Agarwals who has taught us this technique, where I can put the CT segments, and there the iris hook goes out, and then I get an interscleral pouch over there. The hook is now put inside. You can just put it intersclerally, and then as you can see, the scleral goes on. The lens is well centered. And then, as you can see, the sutures. I mean, I just put a 809 just to get that figure of 8. And look at this as it goes. So in the post-operative period, see the well-centered lens. And so in this time, in 2020, subluxation, and then video is playing slowly, and this is what in 20 minutes subluxation in the CT segment. Yeah, I think the video.
Wonderful, Ajoy. Let's ask Dr. Namrata what she thinks about this and how, how useful this can be. Yes.
I think it's a new technique, and it's a great innovation. There are only a couple of things which come to mind, and one is how strong is, fixation of the CT segment, and then what happens to the intrascleral fixation of the nylon hook. Somehow, to my mind, it looked as though it's not going to pull that effectively right up to the edge of the capsular bag, and whether the whether the CT segment also gets pushed right up to the equator there. That is something that needs to be evaluated. And then putting it in the intrascleral again is a good technique to do. But both the sides or the edges are kind of loose, so you don't know that pressure or that tension doesn't come in. So in long term, I think one needs to evaluate as to what would be the fixation, and over a period of time, will that get loosened or not.
Ajoy, we can't see you. Can you switch on your video, please, for a moment? Yeah. Okay. Would you like to comment, Ajoy?
Yeah. I think this is what we have been doing. I think we have done quite a few of those cases, just like any other intrascleral fixation of the IOLs that we have done. I mean, this is bent and this is fixed, and I'm giving a suture at the base of that, a figure of 8 suture. I'm not using glue there. I think this should stay for a long time. Well, only thing is that this was a straight thing which we have curved it and put it. I think this is one of the ways that we are doing it. I think long term is yet to see, but that's what I've started by the end of last year. Let's see how they fare, because the sutures one actually over a period of time they snap off, and many a times there is a fibrosis that goes off. Probably this would stay.
Any of our other panelists wants to make a comment on this?
Would you like
experience with something similar?
No, I was
Yes, I
just
would.
wondering as to why he wants to not use a non-absorbable suture, with vortex suture or whatever. Why? What's the big advantage of this?
the ease. Mahipal, I think it's very easy because you all have an iris hook. Just hook it and just put it. That's what I thought was a comfort level here. There's no railroad technique and no running around behind it.
No, but if you have a submersible lens with you right from the beginning, so you can just plan for a suture being there with you.
No, how does this compare with the tensile strength of the suture itself, which is, tied at both the ends vis-a-vis, this is, it's open at both the sides, this side also and this side also. Ron, would you want to comment on
Ron,
it?
would you say something on this?
Well, I think this was a very innovative idea, and I think last week we had the Top Gun in which Soon Pek presented the humble iris hook, and I think you could very well add this as to her list of users for the iris hook. No, I think I think Namrata, you make a good point. I mean, because the free end is inside the eye around the capsular tension segment, you kind of don't know where that free tip is going to be, and I think that would be my concern also. And with eye movement and eye rubbing, whether it would slip out.
Let's have a final comment from Sam.
Inside the bag.
Yeah.
That goes inside the bag.
One of the most important things about placing either a Sioni ring or a tension segment is titrating the centration of the bag. And you never want to over tighten it. And of course, you don't want it to be too loose. You don't want the bag to flop around. And so I think my preference, I think it's much easier if you're using a Gore-Tex suture and a slip knot, just a 1-1-1 slip knot. You can adjust the tension after the OVD has been removed, after the IOL is placed, particularly if you're using a multifocal lens, then you want to make certain of your centration. And what bothers me is with that Sharioff tunnel for that nylon iris hook, I don't think you can titrate the tension as well. So it saves you the need for suturing, but I don't see that that's a very, very big difference. Also, people are using a flange technique. They're also using Prolene suture to try and do that with a flange technique, but I think it's much more difficult to titrate the tension. And so when you have an adjustable slip knot with Gore-Tex suture, that would be my preference.
Thanks, Sam. I think we are running behind schedule. We would love to speak more, and we have a lot of questions which we'll take at the end. We have our next presentation coming in from Ron from Singapore, and he's sharing some interesting new things that he's doing. Ron, please go ahead.
Yeah, thank you very much. Okay, can you see my screen now?
Yes.
Yes.
Great. Well, thank you very much for having me here and asking me what I'm doing differently in 2020. Well, we're all used to the microscopic view, which is the plan view looking down the microscope. But surgery is a three-dimensional event, and a side or elevation view may yield more information. And I was fortunate enough to really have access to the Zeiss Lumera 700 Callisto rescan system for the last year or so, and which has, of course, the inbuilt live OCT we've just heard about. But, it was originally designed for corneal and macular imaging. So I really wanted to explore whether we could use this usefully in cataract surgery. So let's look at some pictures. First of all, surgical anatomy of the crystalline lens. And you will see here that we can see the anterior capsule beautifully, and we can see the posterior capsule very well when you focus down there. This is a cortical cataract, and when we look at a cortical cataract, you can see the lamellar structure on the right. And if we go to the next, why is my slide not moving? Hang on, guys. Let me see. I don't know why my slide won't move. Hang on.
Use the small arrow at the bottom left, click it and move forward.
Bottom left.
At the bottom left, as you take your cursor, you'll see the arrow for the PPT.
No, you have to come down a little.
Further down, Ron.
Come down.
Yeah, somewhere there you'll see that.
Yeah.
Just click on the right arrow.
Right,
okay,
right,
sorry.
right. Yeah.
Okay, so, and then what happens if you've got a nuclear sclerotic cataract? Well, you can see the nuclear sclerosis very, very nicely shown. What about a PSC cataract? This is a moderate PSC cataract. And if you've got a polar cataract, it's very useful because you can then see whether your polar cataract has actually gone through to the posterior capsule and gone beyond it. We can even see Mittendorf spots. So the resolution of this technology is actually quite amazing. But what we really want to know is intraoperative OCT useful as a surgical aid? Well, I would say here that all the expert surgeons here probably don't need it. but it is useful in all these steps. I don't have time for all of them, but just cover 3 or 4 of these. But I think as a training tool to our residents is great. Now, here's the first incidence in which I think that this technology is great. What does hydrodelamination and the golden ring actually mean? Here you see that on the right, the nucleus is really very, very well isolated. And when we look next slide, you can see that the multiple layers at the back of the lens, and if you look in front, there are actually multiple layers on the front of the lens as well. So the fluid actually goes in many, many directions. Now let's look at live hydrodissection. I guess most of you haven't seen this before. Just watch as I start hydrodissection there. Watch the image bottom right here. I'm doing a very gentle hydrodissection, and you'll see the fluid wave come in there. Now I stop here just to show that if you stop too early, your hydrodissection is not going to go all the way through. Then I go back in now and I'm going to complete the hydrodissection here, and you see that the fluid wave now goes all the way through to the other end very, very effectively. That's complete hydrodissection. Now this slide, I'm just going to show what we do when the nucleus is lifted. Again, this one I'm doing it in one fell swoop. No half measures here. As I inject, I go right through to the other side, and again, you will see that big gap appearing there. Now, you always have to push the nucleus. So watch what happens when I push on the left here, and you see that the nucleus comes down. And that completes your hydrodissection and really makes things a lot safer for you by restoring the anatomical position. Now, Howard Fine taught us cortical cleaving hydrodissection many years ago, and later on I'm grateful for Sam's comments on this, in which after phaco you don't need to do IA because the hydrodissection was so well done that it's been removed. But you know, it's actually quite difficult to achieve, and I would say I don't achieve it most of the time. This is because although I think I'm injecting subcapsularly, most of the time you can see there's a layer of cortex left behind there. Let's move on to the next issue, which I think is the nucleus. Okay, how can it help us in the nucleus? Well, when you're taking your residents, what's the thing that they fear most? They fear that when they're going deep, they're going to hit the posterior capsule. And you can't really help them very much. But now with this OCT technology, you can look at it from the side. You can see how deep they've gone and the shape of the groove that they're making. Is it nice or not? And once that is good, then you can, you know, freeze the image, teach them that's a good shape you want. And when you've cracked it, you can actually image the crack in the base of the nucleus here. And again, these are images that we normally wouldn't see without a live OCT on the microscopes. Now let's move on to the other issue, which I think is very important, and that's the IOL, OVD, and posterior capsule relationship, something we always take for granted. Now, once we insert an IOL, you know, it normally sits on this bed of OVD, and you can see that the lens is tilted, it's to one side. And again, if you don't do anything, you can see that before you remove OVD from behind the lens, there's a huge pocket of OVD there. But if you go behind the lens and suck out the OVD, you can then get this shrink wrap effect of the PC with the IOL sitting nicely on it. Now, you know that many people say that if you're using sitting nicely on it. Now, you know that many people say that if you're using a cohesive viscoelastic and you just aspirate in front of the lens and rock it, and you know for sure that you're in the bag. So what about incisions? Okay, now incisions is another very interesting thing. The side port at the end of surgery is usually a little bit gaping like that. Now, if you can close that side port just by massage, you can see it comes through quite nicely without distortion. But if you hydrate the side port, you can get this very much more swollen looking cornea. What about the main wound? Now, this is what I call a virgin main wound. In other words, the incision has just been made and I've done nothing else. And you can see it's a nice, neatly opposed wound. At the end of the surgery, it doesn't look so well. It's a bit edematous, it's gaping. So this is one that you really do need to hydrate and close it. But you know, if you look at a wound that you can just massage close, it's much gentler without the very big swellings that you see here. See this, you get the dumbbell effect if you do hydrate the wounds tremendously. So I think this is a very useful technique also to really study what we're doing with our incisions. And just to end with, you know, we can look at complications as well. Okay, now here is a case that when you remove the phaco tip, anterior chamber shallows, and you can see the posterior capsule and cortex actually floating right up to the cornea. What's worse is this can happen with an IOL as well. After you've removed OVD and you take the IA tip out, sometimes the chamber shallows and the lens can actually hit the endothelium, as you can see up here. And the final complication I'm just going to share with you is you can see these radial tears here very, very nicely. And I think Rohit, you would be well advised if you can use this technology when you're studying your flat motility sign and to really see the effects on live OCT. So just to end with, I think that live OCT is very useful in cataract surgery. We've got to repurpose it from cornea and retina. It's a great teaching aid in teaching institutions. You can use it as a research tool in the ways I've described. And I think for some people, it will be a great surgical aid. I think for white cataracts, I've noted that for very dense cataracts and white ones, you sometimes don't get it deep enough to see the detail behind. So thank you very much. And thank you for having me again, Gaurav.
Thanks, Ron. Kumar. And I think Namrata uses this a lot. So Kumar, take it ahead. Yeah.
Ron, that was fantastic. I've seen this before. I mean, I always thought it's used mainly for corneal surgeons. They'll benefit the most, the retina guys. But what you've really shown for cataract surgeons is really you've not left any part of it. So that was an excellent presentation. But I think in this whole group, only Namrata has maximum experience with the online OCT. So Namrata, you can, what do you think? And what
I think that was a fantastic presentation, Ron. And you covered everything possible in the intraop OCT microscope. For myself, I can't operate on a normal microscope now. We have about 6 of them in our center, and it's a great tool to have. And I think the future generations are going to get used to it. So my light is gone, but anyway, I will talk. So the thing is that
we are seeing an OCT image of Namrata now.
We can still see you. Yeah.
Okay. So I think it's a great tool to have. You showed some very great tips. We are trying to correlate the distance between the IOL and the posterior capsule, even post-operatively. We are comparing it on the AS OCT. And the new OCT which has come has an autofocus. So it focuses on the crystalline lens. Otherwise, with the previous OCT, a technician had to keep focusing it for you, and you had to keep watching it, on the monitor like that yourself. Yeah, on that like that. And then, keep getting accustomed to it. So, and it has a great role to play even in posterior polar cataracts, because sometimes you can actually, see the gape there beforehand. And if you can't see the gape beforehand, then as you sculpt down there, and the nuclear material that is there, which keeps decreasing over a period of time, then you can make out, that the gape is there or not. So, and of course, small DMDs, because what happens is that the incision side DMDs you have on the side port, main bone, and if you didn't have that, you would think you are done. So, you know that, there's a small DMD which you can see, and then appropriately put air and use it. So fantastic presentation.
I think it's got vast application that's just underappreciated. But I wonder, Sam, whether you'd comment a little bit on the hydrodissection point that I raised just now.
I think I quite agree with you, though I have not watched it that carefully as you have shown it now. But great thing, and I don't know whether you've noticed or not, but in posterior polar, you can actually titrate the level of the hydrodissection by looking at it and just stopping it short.
Sure, absolutely. Slowly.
Yeah, very slowly, stopping it short just at the area, where it might kind of go out. So it has a great potential that way. Super.
A great presentation, Ron. I've been using the IOCT along with the RTO 800, and you can see it on the big screen. So it's excellent. I mean, the technology has improved now, and a lot of applications. You can study the posterior capsule, DM detachments, and a lot of
and
very well demonstrated.
The best thing is the distance between the IOL and the PC. And I think all of us miss that. We think, and you see the gap is going to be so much. And then as you remove the viscoelastic, the capsule will become wrinkly. And as you hydrate the wound, the capsule will again become taut. So you know that your lens is in correct position or not.
Very nice.
Did you try comparing the femto incisions to the manual incisions, and if there's any difference on the OCT at the end of surgery between how well the femto-assisted incisions, how do they compare to the incisions that we make with the keratome?
No, I haven't done that comparison, Gaurav, but I have looked at the femtosecond laser track patterns just to see how deep they are. And as we all know, it doesn't go all the way through, and it's actually quite quite interesting. I mean, there's so many things we can do with this technology.
We've published, Gaurav, comparing femtosecond laser wound on IOCT vis-a-vis the manual ones, and there's a paper which is published in JCRS. And
what does it say? What does it say, Namrata?
The architecture of femtosecond wound is far better as compared to the manual ones.
Great.
Especially when you hydrate, they tend to close a lot more times as opposed to the ones which are manual.
Could we hear from Sam now? I really want to hear what Sam has to say about that.
Well, I'm going to comment on what you want me to talk about, but there's one other thing that we've not heard yet. And I'm very, very much interested in heads-up surgery in terms of the ergonomics and the effect on our musculoskeletal systems. So I don't know if it's going to come up in conversation. Somebody alluded to it much earlier when we were talking about masks and microscopes.
Yeah.
So I think also there is a virtual reality system that comes out of Israel. Unfortunately, that still has to be tethered with a cord. But either looking at a remote screen or working with a VR set, I think is going to be very important for the future in prolonging our necks and musculoskeletal systems. Ron, you were curious at my comments about the cortical cleaving hydrodissection that Howard gave us. I love the serendipity of life. It just happened to him a few times and he realized what he was doing. It is a time saver. I never liked it, however, and the reason I didn't like it, it often left little wisps of cortex that were smaller than the aspiration port. And so you could actually get, you could, very hard to get out. So it was actually, I think, I didn't use it very much. I didn't attempt to do it because I could clean the cortex better. And I never considered it a horse race. To me, it was better to get the job done as well as you could rather than as fast as you could. So that was, so I never liked it. But if we had now onboard OCT in those days, we would have seen it a lot better. It's really great stuff. Thank you.
It's really harder to achieve than you think it is, because each time I think I'm there, I'm not.
Right. Thanks, Sam. Thanks, Ron. I think we need to go on, and we have a really interesting, we still have 3 more presentations and really exciting ones at that. And I'll invite John to please share his presentation. Now, John, for the audience, I would like to share with them that John from Hong Kong is telling us about how he's been, in his practice, being able to kind of improvise and change how things, how he's doing things with the COVID-19 experience, and how Hong Kong, is one of the countries which we didn't realize, had one of the first, after China had one of the first few cases come in, and then, now they haven't had a case in a few days, and they've been able to come back to almost full practice for their cataract and refractive surgery in their practices. So let's hear, John, how you tell us the secret of how things can be made better for us.
Okay, yes. Well, I'd like to say there's a light at the end of a tunnel. We're about, Hong Kong, we're about 2-3 weeks ahead of you. Let me share with you, in Hong Kong, we have 7.4 million people. That's almost as a population as New York. And yet we only have confirmed cases of just over 1,000, 4 deaths, and now we have 990 recoveries. Now, China also has actually, they've now pretty much completely back to normal life now. People are traveling around. May, they have the National Day and everybody was traveling around. This is just to show you what happened to us in Hong Kong. And about early January, that was our first case of COVID. Now, if you look at this, the color, just going to roughly show you, the blue are the local cases. And as soon as it happened, as you know, we had SARS in 2003. So it was really a painful experience, but we learned a lot. So as soon as we heard about this COVID in China, Wuhan, everybody wore masks. And I'm going to talk about how important it is to wear masks. And you can see we really controlled everything very, very well until around mid-March, when there was a rush of young students coming back from UK and from the US. Unfortunately, they came back, they went out at night, they partied, they went to bars, they went to restaurants, and they did not wear masks. So that created a huge, massive local outbreak. So all the blue are local outbreaks, okay? So it's really quite scary as it goes up. So the government immediately closed all the bars, and they set rules, and I'll show you the rules of what we did. And it's only really now recently that it's gone back down to control. So they blew all the local cases, okay? And in the last about 17 days, until about 2 days ago, we had 0 local cases and just a few imported. But unfortunately, 2 days ago, we got 2 local cases. We were still kind of chasing after this. But I'm going to talk a little bit. Now, as I said, as soon as we heard about the thing, this COVID, everybody started wearing masks and changed our social behavior. Now, why is it so important to wear a mask? If you look at this, this is the incubation period of COVID-19. The average incubation period is 5 days, okay? And 97.5% are symptomatic by 11.5 days. But the problem is, before you are symptomatic, you're already infectious. So these people are asymptomatic up to 11.5 days. And some cases up to, there was one report of 27 days. They're walking around infectious. So this idea about wearing a mask when you are symptomatic to protect others or is no longer valid in this situation, okay? So it's very important to start wearing masks right from the beginning. And it's very important in your clinic to teach your staff so they know exactly what's going on, okay? Now, what about the restrictions on entering Hong Kong? All non-Hong Kong residents coming from overseas were denied entry. Non-Hong Kong residents coming from the mainland, Macau, and Taiwan will be denied entry if they've been overseas in the past 14 days. For all inbound travelers, if they are asymptomatic, so they have no symptom, but remember, they can also still be infectious. So they have compulsory quarantine at designated places at the home or accommodation for 14 days. And during their quarantine, they actually wear a wristband, okay? And the wristband is actually attached, connected to an app that loads onto their cell phone. So the government knows if you leave your home, okay? The wristband and your phone. And actually, the people actually Hong Kong very cooperative. If they see you out there with a band, they report you to the police right away, okay? So you get sent to the hospital, okay? And you get quarantined there. So that's very helpful. And also, they have surprise phone calls from the health authority and also surprise visits from the police or the health authority at home to make sure you're staying at home. So these are the way we make sure these patients under quarantine are staying at home. Now, all asymptomatic inbound travelers now arriving in Hong Kong, these are only residents now of Hong Kong, okay, nobody else. They have an enhanced lab surveillance program where they have to wait for their deep throat saliva test at the airport, or if they need to wait overnight, we will have temporary accommodation at designated hotels. If they're symptomatic, they are transferred to A&E, okay, the emergency room for tests required. Now, until 7th May 2020, when we had the outbreak in March, everything was closed. Movie cinemas, amusement park, everything, okay, except restaurants. And also government had, in order to reduce gathering, prohibit any group gathering of more than 4 people in any public place, okay, except in transportation, in law courts, magistrates courts, okay, and at funeral or wedding ceremony, no more than 20 people are allowed, and there's no food or drinks served. Schools and churches were all closed. At the restaurants, they kept the restaurant open. They closed the bars and the pubs, but the restaurants, the tables have to be separated by 1.5 meter or have, and actually have partitions, and they limit 4 people per table. You can only take off your mask when you're eating, and they measure your temperatures before you enter the room, and they provide hand sanitizing gel. You have to sanitize yourself. And as of May the 8th, we have, as I mentioned, we have no local cases, about 17 days, but as I said, 2 days ago, we got a couple of new ones. Group gathering now is relaxed since Mother's Day. They relaxed it on Mother's Day. So now we can have group gatherings of 8 or more individuals rather than 4. And the cinemas, gyms, beauty parlors, and bars have actually reopened. And the high schools will resume in the coming weeks. The city is considered free of local transmission after 2 14-day periods. That's 28 days of 0 local cases. Now, our hospital, what are we doing in our clinic, in our hospital? We have a hospital in a residential area, and we actually have a clinic in a business district in a commercial building. So we have no restrictions in booking on local patients without travel history in the past 14 days. But the following symptomatic patients with travel history in the past 14 days, symptomatic patients who are close contacts with confirmed cases, asymptomatic patients that are under quarantine, and asymptomatic patients who are in close contact with confirmed cases are not allowed to make a booking. So when they call, we ask them all these things. And we limit to 2 accompanying persons per patient. So they cannot bring the whole family along, okay? So only 2 accompanying patients. So when they come to the door, or sorry, when they call to make a booking, we have some questions that I'm going to show you down below. And when they arrive at the door and they sign in at the registration counter, we ask them 3 times the questions below. In the past 14 days, do you have any symptoms? Okay, like sore throat, cough, fever. Have you been traveling outside of Hong Kong? Are your family members been traveling outside Hong Kong? Are you in close contact with confirmed cases? And have you or your family members been in contact with confirmed clusters? Because we had these wedding banquet clusters and large gathering before we restricted the group that were actually spread starting a lot of local breakouts. So when they sign in at the registration counter, the question will be asked again. So they've been asked 3 times. It seems like it's very obsessive and compulsive, asking these questions repeatedly, but it actually shows that we are very cautious and actually impart a sense of security in the patients, so they feel safe coming to you. Now, our staff at the door, at the entrance, have on full PPE, that is personal protective equipment. They have temperature check, patients are checked, they have a temperature check before they come in. They have alcohol rub, and we ask them to rub their hands. And people without a face mask will not be allowed to enter the hospital or the clinic, and they have to keep their masks on. And we have visit logs, a registration required for all patients. Now, what else do? We distance you see we have a perspex covering that separates the 2 sides. We have these acrylic partitions. We have separate lunch hours, so we make sure there's not a whole group there. So only 2 or 3 are having lunch at the same time. We reduced our doctor's clinic, so we didn't start them right away. Obviously, you don't have all the patients come in anyway. So we had sessions reduced. So we're concentrating at a certain time. And our surgical sessions are mostly arranged late mornings and early afternoons. This way, you reduce the manpower and you reduce the risk of staff infection. That's very important, because if your staff gets infected, the whole clinic closes down. And now you've been everybody says, oh, your clinic has an infection, and everybody keeps away probably for a few months. Now, you probably have seen this already and you know all this, but we make this a slit lamp shield here, put between the eyepiece and the main body of the slit lamp, a little further away. Some of them, you hang it on the eyepiece, but it's touching your face. So it's very annoying. So this, we just use a plastic book cover. You know, you have these book binding covers. We make a hole here, we cut it at 12 o'clock, we split it open, and then we slide it into here, which is very nice. You got the big piece, you can make them as big as you want. But this is just a regular, you can buy from a bookstore, stationery store, a book binding cover, acrylic one. So that works very well in protecting you and the patient. Now, we don't use Goldman tonometry, because if you swing it into place, that thing actually touches the patient's mask. Sometimes they even touch their mouth. Okay, and when you swing back, your hands are contaminated. So we use either the NCT, and we actually clean the machine every time we use it, because as you know, it sprays, it can spray the bugs around. And the other thing we use is the eye care, which is disposable. We do it every time. At the moment, our clinic, as I said, we have 2 locations. People are a little more concerned about going to the hospital. So our clinic at the hospital is now back volume by 60%. Our eye surgery center is by about volume is back 50%. But our outside clinic in the business district is back 80%, and our refractive surgery, LASIK, SMILE, is back now 100%. And in fact, some centers in Korea have reported that the refractive volume has increased to 100%, so 20% more than their usual. And this is actually due to two main reasons. The younger patients are not as concerned about the virus because they're less prone to death. So they're not quite afraid. And actually, most of them just get a little fever and they actually recover. So they're much more brave in turning up to your clinic and having the surgery. And also, a lot of them are working from home right now. So they have time, they can afford time to have surgery without needing to take official time off. And as usually the business is not quite so busy either. Now, we never locked down, fortunately, okay? We were allowed to go to work. Home office was encouraged. Nearly 100% wear masks when they go up. Frequent hand washing, portable alcohol hand rub, no handshaking, no hugging, and no kissing. Each person have one pair of chopsticks for eating and the other pair for picking up food. So we don't even, not only do we have like a communal thing, but you have two separate things yourself to pick up things, and you pick up with one and you eat with the other. So then you don't infect people. And most people stay at home after work and on weekends. So in conclusion, social distancing and masks slow transmission and prevent large outbreaks. It allows time for contact tracing and tests to keep up. Surgeons should pay more attention to earlier opening of your refractive surgery center rather than your cataract surgery center. One thing is, before you go back, maybe if you have time, you should check your stock of frequently used items. We ran out of riboflavin for LASIK Extra and then found out that the US suppliers could not supply us with the riboflavin. So, and so we would decrease our booking, beforehand, and then, look at the things that you might need and talk to your supplier and make sure that they have enough supply. Thank you.
Thanks, John. That was remarkable, and I think lots of lessons for us. So before we go on, one quick question. I'm sure we'll have lots of questions for you. What kind of tests are you doing before taking up patients for surgery, like for cataract or LASIK? Are you doing a COVID test or anything else, or you just go ahead after you've taken the history?
No, we because we don't have any local outbreaks, so we don't do tests on them. We thought about doing tests on our own staff as well, but there's still rumors about even though you're infected and you get better, you may still get affected again because the virus mutates, which is, I don't think is true. But so we don't do them tests. We actually I think that we test on our own people and find out there's some positive, it might actually scare people away. For people in Hong Kong, because there's no more local outbreaks, we're not so worried about that.
So during the time that you had that peak, which the curve which you showed,
yes.
During those days, how were you doing? We are probably going to get peaks in our country. Few cities are already getting that, and we may get in some others if we are unlucky. So during those days, how did you improvise with your surgery and other stuff?
Well, as I said, the people come in, they all masks. And the only time they're off the mask is we take off the mask and then we clean, we betadine the eyes. So for both refractive surgery and cataract surgery, and they go into the room, but the rooms are clean and sterile, and we're all covered and masked, and we all have our PPE on, so we're well covered. And once we're done and they come back out, we actually also we ask them to wear their masks again. So that's it. We don't really do the tests. I think they're well protected. We are well protected. I think that we don't really need to do the COVID tests. And sometimes recently there's a recent one that comes out and they say there's only 50% accuracy. So no, we haven't been doing any tests. Only if they get admitted into the hospital, and if they're in the hospital and they develop a fever, then we do the COVID tests on them. And if they're positive, we send them out.
Dr. Ramamurthy, I think you wanted to ask something, or
yeah. John, excellent presentation. A lot of lessons to be learned.
Yes.
One thing, I think two things which worked for your country as a whole was that masking, as well as the fact that you shut your doors and didn't allow international travelers to come in. And I wanted one simple question. What are the kind of masks your general population was using? I mean, it was cloth masks, or was it 3-ply masks, or what kind of masks were they using by and large?
I think everybody just wearing surgical masks, the usual ones that we wear in surgery. It has 3 layers. The inside it absorbs water, and then the outside layer is waterproof, and then there's a filtering in the middle. It works well. You know, we have other like cotton masks, but they don't protect too well.
No, he's asking the general population. What was the general population? What was the general population wearing?
Yeah, they're wearing the surgical masks.
So they were disposing every day, every intervals?
Yeah, we had a problem. You know, people were wearing it for a week with the same mask. And everybody was getting pimples and everything because it's so dirty. But, you know, it's better than no mask. But now, you know, we have a big supply from China. We're making our own masks as well. So, you know, in our clinic, you know, we had a problems with also in the hospital. So the hospital was giving us 1 mask in the morning and 1 mask in the afternoon. So you're going to have to, when you go into surgery, obviously you change your mask. But the general public just wear surgical masks.
Ron, you have a lot of patients happening in Singapore right now. Like I saw yesterday, there were about 900 new cases or something like that. So how are you guys changing? Because, you know, you may have a situation closer to what we have at home. You know, John is already out of it. So how are you guys improvising for your surgery, and are you doing tests and stuff?
Well, you know, Singapore did very well right at the beginning. You know, we kind of instituted all some restrictions, but we kind of dropped the ball with regard to the foreign workers who are living in very crowded surroundings, which is sort of like sometime in March, late March, we could see that the numbers were going up, and then the government did something about restricting them. So basically we've been on, they don't call it a lockdown, but really it's been a lockdown for March and April. So we're only allowed to see really essential cases. So I go in once a week to see a handful of patients. You're not allowed to do routine cataracts, routine LASIK. Any routine surgery is not allowed. I mean, you can fix retinal detachments, you've got acute glaucoma, but I basically have done no surgery for 6 weeks now. And they say that this is going to go on for another 2 weeks till June. I think now there's very little local cases, like John was saying, you know, in Hong Kong, when you don't have local cases, you feel a lot better. So the local transmission is very low, maybe 2 or 3 cases a day. The 800 or 900 you see are all in those the migrant workers who are all now housed in separate dormitories to try and contain it. So I'm hoping that in June they will relax things. But you know, a lot of our patients come from overseas, and I think, you know, we're going to have a problem because the Indonesian patients won't be able to come to Singapore, and so I suspect we're going to have a pretty slow period before we can really get back to anywhere near.
So for those patients that you do operate, do you do any tests? Like, are you doing for those that, you know, like the RD, retinal detachments, or any emergency other surgery that you do?
I think, like
are
John,
you doing any tests?
I think if they are asymptomatic and without indication, we don't. But if patients you don't have contact or have symptoms, we don't even see them. You know, we get them sent away to get tested.
That's right. We just don't even see them. So
Yeah,
if they're in close,
even see them.
yeah, if they're in close contact to anybody high risk, we just don't even see them. We don't accept them.
Because John says,
if they have
if
an
one of our
emergency,
staff gets it, we're closed down.
Sorry?
If one of our staff gets the COVID-19,
exactly,
our whole clinic will be shut for God knows how long.
Exactly. Yes.
So what's your opinion on surface treatment? You know, there's a controversy here that people are saying that you can do LASIK and you can do SMILE. What's your opinion on doing surface laser for COVID patients? I mean, for refractive surgery, would you do this surface treatment? Would you do C3Rs now, or would you delay?
In short, do you think are they aerosol generating procedures?
Yeah, well, we still do them. I mean, the laser, when you're firing on them, it's a UV laser. So in theory, it should sterilize it. But you know, you have to. When we're in the operating room, we wear a different mask. It's you know, it blocks the fumes and everything. So it's much higher protection for us. And then if we're doing surface ablation, you're right, we do clean the room much more carefully than if we did SMILE or LASIK.
I think you mentioned in your presentation that you do NCT and not explanation tonometry. And we think otherwise that NCT may be an aerosol generating procedure. So would you comment on that? Because
yes, it is. We were concerned about that. In the beginning, at its peak, we did not use the NCT, just like you're worried about, because the aerosol. and we just use the eye care. We didn't even do applanation. We're not even doing it now. But as we have no more local cases, and we're so strict about the people that we see, pretty much lowers our risk. So we're back to the NCT, but we use it only when the doctor requires it. So we do it on, say, post-cataract patients, maybe post-LASIK or something. We try to decrease our numbers of IOP measurements.
See, Namrata, the problem, what he said is if somebody is wearing an N95 mask, when you bring the slit lamp, so it actually touches that and it pushes back the rod of the Goldman, the applanation tonometer, and the readings are pretty much not accurate. So that's the logistic problem of doing an applanation, but otherwise applanation can be done if that is not taking maybe by tilting the face, etc. But I think ultimately the eye care would be better. But all that everybody is saying is that until, of course, actually mandated, you can postpone taking the pressure.
Right. That's right. We try and decrease our as much as we can not to measure them.
And Kumar, to your question also, the thing is...
I'd just like to add one thing here. What we do in our clinics...
Take a second.
What we are doing in a...
is very, very certain is that any patient with any type of history, you mind what he said. He said 3 times we take the history.
Yes.
So basically, you are not dealing with COVID patients. They are just not allowed to enter. That's what he's emphasizing. So ultimately, you have to be very, very careful at your screening desk and take the history. And then the problem is we may not be as good because they have that bracelet or whatever he said, where if a patient is around, it will be. So Arogya Setu is something that you definitely need him to download that app and try to be very, very careful that you don't allow anybody who has been in exposure to this thing for a COVID, and just don't let them enter. So you are not actually operating them.
Right.
Wonderful. Kamal, you wanted to say something quickly, and then we go on.
I just wanted to say, I agree with Dr. Mahipal that that's what we've actually resorted to finally. We were not doing any NCT to start with. Then we were doing applanation, but there are some patients who wear funny kind of masks which are like a duck. They have the beak sticks out. So you cannot do an applanation in them. So my glaucoma team came to a conclusion, sir, that let us decide who needs an applanation also or not. So nobody is being given a tonometry till the glaucoma surgeon actually thinks it needs, and then he does whatever he needs to do. So we've just taken the tonometry out of the system for the moment.
Just one question, John. I mean, you said that the people at the entrance and inside the operation theater wear full PPE suits.
Yes.
You mean the full what is worn in the ICUs, or it's a modified form? Because I'm told that we are not doing it in India. And I'm told it's extremely uncomfortable to operate with these suits, and maintaining sterility is also a challenge.
Oh no, we just wear the usual outfit. It's only the person at the door of the clinic or the hospital. People are coming in; they are in full PPE. So they will to take the history. They do the temperature measuring. They ask the people to alcohol rub their hands. But once they come up to our surgery center or they enter the clinic, we're just wearing masks. The doctors, we have scrubs. We wear a white coat. Some of us wear the eye shield and then a mask, and that's it. So it is very uncomfortable. But no, because fortunately we are able to control our local the infected cases. You're right. It's very uncomfortable wearing that, So we have a hospital policy as well that before, but now it's if we've been outside and we come back in, and then we have to do that. We have to be self-contained at home, and then we have to self-quarantine at home, and then we have our blood tests. So we do the deep test, and then we in the PPE after 4 days. For another 4 days, and then we do another test. And if negative, then we can take off and just wear usual masks and things like that. So we do tests if we believe our own staff are as high risk.
John, one question.
John, I think, okay, John, last one, Dr. Kudlu, and then we go to SriGanesh's presentation. Yes.
Just my question, if the patient comes with the refractive surgery, Do you prefer to do either your first preference, either smile or any of the PRK procedure? Or second question is whether you have to wear, as a doctor, whether you have to wear any protective glass, and in between, suppose if you are having 3-4 cases at a shot in refractive surgery, do you have to keep a gap? Suppose after one surgery, keep it for 20 minutes UV light, this one fumigation, like to make the room clean, then followed by do it, or at a stretch you do 4 cases?
Well, if we do the PRK, probably leave it at the end of the list. That's probably the best thing. And then, smile is probably the safest at this time of the year, because, you're not spraying everything away. And, like with LASIK, what I do is I actually, some of the lasers, say like the shrink, you actually can step on it first, and it starts the suction first. So it takes out all the fumes, and then you do the treatment, even in LASIK. So yes, there are things that you kind of need to consider about that. For eye protection, because you're actually sitting there looking at the eyepiece, in theory, you're away from the treatment, and then your laser should be, once you get the current going, it should be sucking out everything anyway. So we're not so worried about that.
Thanks, John. I think we'll quickly go on. Ganesh, if you're ready, thanks for waiting so long, but we've had such a tremendous discussion. So go ahead, SriGanesh, and then to finish it off, we have Master Blaster, Dr. Rohit Om Parkash with his innovation. Yeah, and thanks to the audience for bearing with us.
Good evening, everybody, and thank you, Gaurav and IIRSI for inviting me to this webinar. Let me just bring up my screen. I'll be presenting on okay, can you see my screen?
Yes.
Yeah. So this is about IOL explantation, and then there are many indications for IOL explantation. Sometimes you may have to explant a lens if you have had a refractive surprise. Sometimes the lens can get damaged, either the haptic or the optic can get torn. Otherwise, you can have opacification of the lens or malposition of the lens. So there are some indications for explantation of an IOL. Now, there are different techniques of explanting an IOL, and most of them involve sectioning the IOL, which can cause some issues. I'll just start the video and we can look at the normal techniques which most people use, and then I will present mine. So one is complete sectioning of the IOL. You can go and support the IOL with a dialer or a forceps, and then put in viscoelastic under the capsular bag, then take a scissor, usually a cannulated scissor, which can go in through your main incision, and then you can cut the lens 3/4, rotate it, cut it, and then remove the 2 pieces. Now, the whole problem with putting a sharp instrument into the eye is that you can't touch the cornea, you can touch the posterior capsule because it's blind, you don't know where you're going with the scissor, and this is a risk that you can have a PCR. So in this case, of course, we tried to rotate, then we sectioned the lens and then removed the 2 pieces. The other technique is where you don't have to completely section the lens. You can partially section the lens and rotate it. And this is a silicone lens. Here, you bring out the haptic first to the main incision, put in viscoelastic, hold the haptic. Here, I'm using the MST forceps and the scissors. You cut it 3/4 of the way through. Then bring out 1/2 of the lens through the incision and rotate it. So you can just rotate it out and bring the lens. Now, can we do without sectioning of the IOL? This is a very important aspect, because when you put in a sharp instrument, there is a chance of you damaging structures, especially the PC, when you go behind the IOL with a sharp instrument. So I was thinking, why not do without the scissor? And then this is the technique which I'm using now. And the principle is the wound. So you can see here, this is a case where we had to exchange the lens. And this is the normal 2.8 incision. So what is very important, the principle behind this technique is that you make a trapezoid incision. So you convert this rectangular incision into a funnel-shaped trapezoid incision. So this is the trapezoid incision where the inner lip is much bigger than the outer lip. I'm staining the incision with trypan blue just to show you the configuration. So you can see the configuration there. It is a trapezoid incision where the inner lip of the incision is bigger. And after that, you can put in OVD. You go in and you lift the lens off the bag. And you bring one haptic out into the anterior chamber. Then you go in with the forceps and pull the haptic out. Now you can, once the haptic is out, then you can hold it with a McPherson forceps, the haptic. So I'm holding, I put in viscoelastic. Here I'm using Viscoat, and I put it in just in front of the lens to protect the cornea and the incision. So that's the Viscoat being used. And after that, I hold the lens with the McPherson, go in with the MST forceps, and just hold the lens in front of the haptic there. You can see that's where I hold the lens, and then I twist it counterclockwise. And as I pull on the haptic, I keep twisting it, and then I'm able to deliver this lens. It folds on itself, and then I'm able to deliver it out through the intact incision without putting the scissor. So the, sorry. Something happened there. Can you see my?
We saw till it's halfway in the wound.
We can see your screen, but we saw the lens almost come out. So I think we got the message.
So
yeah.
So that's basically. Then I show you the measurement of the lens. Let me see if I can again.
You have to close this window because this is your email which is showing. So I think first you'll have to close.
Okay.
Your screen is showing at the back, but the Zoom window has to be this Gmail or whatever is sharing instead of your presentation.
Okay, I'm opening the
so you have to,
Zoom,
yeah, you have to
Zoom application.
So just open your presentation,
No,
it will
just-
come over there.
You have to
Yeah, just go to
move
PowerPoint
out
at the bottom and
move
click
out
on
of
it.
the Zoom window and click on the PowerPoint. It will come.
Namrata, next webinar on how to Zoom.
No, I just hit a key on the.
But we could see the lens.
No,
Okay, you could see the lens coming
Yeah,
out, and then I just measure the incision. So the external incision is 2.8.
Gaurav, SriGanesh, I suggest you go to stop share.
And then
Once
share
you go
again.
to stop share and then go and share again, there will be two windows playing side by side. There will be one window of your video and one of your presentation. Click on the one, yeah, this one. Now play again. Now you'll get it.
Let me just move
Play
this.
back again. Yeah, now we got it.
Oh, no. Let me just show you the. Okay, let us start from here. So this is how I deliver the lens out. You can see that it is out, and you can see that the lens is undamaged. It is, you're able to expand the lens without damaging it, and the lens is intact. Okay. So now you can put in OVD and inject the new lens into the capsular bag. And you can see that the wound itself is quite nice. There is no tear. And if you measure the wound, it is 2.8 external incision. You can see it's 2.8, and then the internal incision. So the key here is to have a trapezoid funnel-shaped incision, because then you can deliver the lens. Even if you look at the cartridge, it usually is wider and then it becomes narrower. So the principle is that it has to be wide, and then you are able to, you can see the internal lip is 4.8. So there's a 1 millimeter difference because it's a funnel-shaped incision. So the funnel-shaped incision is very important for explanting the the lens. Let me just stop share. And this is something which is like nature. If you look at the delivery of a baby, also the shape of the womb, it's funnel shaped. It's how easily you can deliver out the baby naturally. Even in SICS, when you want to deliver the nucleus, you have to make a funnel shaped incision. The inner lip is usually larger than the external lip, and then you're able to deliver the nucleus easily. In a rectangular incision, it's very difficult to deliver the lens from the eye. So this is basically the principle. So all you have to do is convert it into a trapezoid incision, and we have seen that the induced astigmatism is also not much. It's less than 0.2 if you do this technique of trapezoid, and it's a very easy and a safe way of explanting an IOL.
Thanks, Ganesh. Any quick pearls from our comment from our panelists?
Can I make one
John.
comment? Sorry.
First, John.
Yeah. This is actually exactly what I do when I remove the ICL. And
I agree.
injecting
I agree.
viscoelastic, you know, because you have the tunnel and it's very easy to take out. But when you're injecting the viscoelastic on top of the lens, that's a very good idea. It's very important to inject beneath the lens as well to push that iris away. Because when you're taking a big lens out, you may catch the iris, and that comes up with your, you know, when you decompress the eye, the iris can come up. And so you got to really be very careful when you're taking it out, and hand over hand like Sri was doing, and you watch that iris, because if it comes out and you pull the iris, then you've got a big iris tear and you're in trouble. So that's I
had already put in viscoelastic underneath the lens.
Yeah. So I know you did.
Just before removing
I know,
it.
I'm sure you did. Yeah. But I'm just trying to stress the point.
Yes.
I think Dr. Mahipal wants to add something.
Yeah, so I think what Shiri showed is absolutely a good technique. The only thing is that it will depend on the hardness of the lens as to. So I think it might be a little difficult on the 3-piece like the Technis 3 or the Sensor because they don't mold that well. They'll need a significantly larger pressure. But these are, for example, if you have a hydrophilic lens, or as John was talking about an ICL and all, they will be much easier because they will go within the incision and come out, because these Technis 3 cartridge or the Sensor 3 cartridge, you know, it's much tougher to hold these lenses. So I think the malleability of the lens also needs to be considered while you're removing them. But otherwise, it's a fantastic technique. Otherwise,
basically for the ICL is very thin, so even without having a funnel shape, you can remove it. I have demonstrated it quite a number of times.
I agree.
But for these rigid lenses, basically you need to have a funnel. Even we have tried it in other lenses also. In fact, the Alcon lens is much easier because of the higher refractive index. It's much thinner. This was actually a thick lens. It was a 23 diopter lens, and
for Alcon lens, possibly you don't even need to extend too much. It just, you know, you pull it out and it kind of comes out.
No,
but even the other lenses, even the silicon lenses, you can do that. But the main principle here is that you need to have a funnel.
Okay, last comment. Kamal, quickly, you wanted to say something?
I think I agree with SriGanesh. Whenever you take out the ICL or the IPCL, you do not need to dilate the wound because the lenses are so thin and soft. I would just want to, for the benefit of the audience, not every time you may need to expand the lens. You can also go in with a piggyback procedure in case of an IOL surprise. In case all your parameters are safe and the surgeon is not comfortable in explanting the lens, you can go in for a piggyback. You can put an ICL or an IPCL or another procedure.
You can do LASIK, you can do PRK.
Well, actually, that's actually a different topic altogether. Yeah. So thanks, everyone. And I think, you know, Shri, all I would love to add here is that I'd like to inject a new lens before I remove or do any cutting maneuvers. Not with this case as you showed, but typically nowadays, if I have to explant a lens and put in a new one, I will go and lift this lens out of the bag and move it up and cover it with viscoelastic on both sides, inject my new lens into the bag because that gives you that added safety, and then do the cutting of the optic and trying to bring it out because your PC is completely protected. And, you know, for me, it works really well. So I think we'll go on to our last presentation unless somebody has anything really important to say or add here. Yes, Dr. Ramamurthy.
No, I sort of agree with Mahipal, what he was saying regarding 3-piece lenses, because this may not work for them. Not only it's a question of the make of the lens, but also the fact that I have found that when explanting, the haptic comes out of the optic sometimes, and then you just have the lens lying inside, and it's a bit of a problem to pull them out. So, but in these single piece lenses, since it works as a unit, this might work well. But ICLs and IPCLs, as some of you have said, I've always found it quite easy to remove them through a natural incision of even a 2.8 or 2.4 millimeters.
I think what's important is a good forceps. That's the key. You know, if you're holding your lens with a great, like the MST forceps, which SriGanesh was using.
I use a bent needle holder. Gaurav, I use a bent needle holder. I just get it out with a MacPherson and I hold a blunt needle holder, N block, and I pull it out the ICL or the IOL. You get a very good grip with a needle holder.
Right. For the ICL, I use the ICL holding forceps, and for the IOLs, I use the MST. They work beautifully well. So I think let's go on. You know, all of us have our own ways of improvisation and our favorite stuff. Dr. Rohit Om Parkash, sir, you have to do the, the grand finale and hit the ball out of the stadium. Let's see what you have to share.
Yeah. Is it shared now? And am
Absolutely.
I audible?
Oh,
yes. Thanks.
Yeah. So I would be dwelling into, innovations, making phaco more meaningful. So what am I doing differently? So there are quite a few things which I've been doing differently, which I would like to explain. The first is the chopper shield in black cataracts. We have already talked about the MyLoop and the femto working, but we are doing nothing to protect the endothelium being hit by the differentiatingly chopped nuclear pieces. So I would like you to see how you can place the chopper between the phaco tip and the endothelium and protect it all the way in such a way that the chopper acts as a shield. So it's being smartly readjusted all the way to achieve crystal clear, pristine clear corneas on POD day 1. So this is how you can protect the endothelium and have pristine clear corneas on day 1. Next is the subcapsular plaques, and I would appreciate Dr. Deepak for introducing things. So this was a small pupil I would have done without, but since it was fibrotic, I thought I'll use the hooks for that matter. The click here is to create a rhexis within the fibrotic or the capsular plaque. So a capsular rhexis has been created within the capsular plaque, or you go around it. Now, once that is done, what is the next thing? You have to separate the capsular plaque from the anterior capsule by all means. So that is being done. So I'm separating it all the way around so that there is no connection whatsoever between the anterior capsule and the subcapsular calcified plaque. So this is what has to be done from all sides. And once that has been done, you can try to take it out. But here you will find that I'm trying to take it out, but there are still adhesions. So you go in again and then separate them fully. So separation is the key. You can use visco also to separate. But I found that this, spatula, the flat spatula, helped me to take it out. So all these calcified plaques can be managed by separating them and taking them out eventually without any issue. So once that is done, the capsular rhexis can be enlarged without much of an issue, and it can be completed with great ease. As you can see, it has been done, and the phacoemulsification can be carried out after that, and it can be eventually completed. So this was the second new thing which I was doing. The third is the reverse angled initiation in intumescent cataracts, which I talked before also, because this helps in making everything come under your control, even if you have to struggle a bit. So reverse angled initiation should be done in intumescent cataracts because that also helps. As has already been discussed in the previous ones, where do you have to put the visco? That is the place where you have to, so that you bring the flap back. And once that is brought back, So, after debulking, the capsulorhexis can be eventually completed. This was the third thing which I was doing. And Morgagnian cataracts are a big problem for each one of us, because the dancing nucleus makes your heart dance, because you are not sure when you will hit the posterior capsule. So the best way out is immobilize it. And how do we immobilize it? Take the capsular support. And once you take the capsular support without any problem, you'll be able to do that. So that was the next thing which I was doing differently in 2019-20 this year. So that is the immobilization technique. Next is, I would like to compliment, I saw this video of the great Dr. Kumar doctor, and you can see these striae. So these striae, if you see, so as you can see, these striae are extending beyond the capsulorhexis margin. So these in all probabilities are anterior capsule striae. So you have to use in these conditions sub-adjunct to give the support, a horizontal support for that matter. And in these cases, you can use a CTR for that matter. The last but not the least, after this, you will find, so is the posterior capsular plaques, which I have started managing lately. This was a patient who had been done with the vitreoretinal surgery, and the surgeon wanted that we should, keep the posterior capsule intact. So in that, you have to create a cleavage plane. So the cystitome can be used. It need not be at 180, it should be more. Once that has been created, then you can easily guide it out in such a way that you can leave an intact posterior capsule behind and make your posterior segment surgeon happy. So this can be tried, because at times you find that there is a posterior capsular or a capsular plaque, which at times can be because the patient has come for quality of vision. So in those patients, these capsular plaques can be easily removed. And then, you can see how crystal clear it is. So that these were the things which I was doing lately in this 2019-20. Thank you very much for your kind attention.
Lovely videos, Dr. Rohit. And what you talked about, Kumar. Kumar has won the best video award in the ACRS for that video on the posterior striae. So I think this weekend, the ACRS, we are going to have Kumar receiving his virtual award in the film festival for his video. John, you wanted to comment on this, I thought. Yeah. John, you wanted to say anything? We can't hear you, John.
Unmute.
Here we go. Can you hear me now?
Yes.
Yeah, a beautiful technique. Very, very nice. I think all these fibroses, I do that too. Just gradually peel it. Sometimes inject some viscoelastic underneath. It's very nice, beautiful, very good. Sometimes with the plaques, I just cut through them. Use scissors rather than, if I have problems peeling it, just use scissors to cut through them. Then I just leave the plaques in.
What stood out was that I think there was silicone oil in C2, the PC was bulging forward, and these capsules are really, really unhealthy. Sometimes, Dr. Rohit did it so beautifully. I was kind of holding my, it was heart in your hand kind of a situation, because, these PCs can break so easily, sometimes even with the minimal of polishing. And, these plaques are, in fact, as John said, if there was no silicone oil, I would sometimes have to cut them and bring them out if they don't clean up. I think Kamal wants to quickly add something. Yes. Can't hear you, Kamal. Please unmute yourself. Yeah.
I think, Dr. Rohit, wonderful videos as usual. What I would suggest is sometimes the capsule is so fibrotic that the needle doesn't go through. So you need to get a way in. So I use an MVR to make my way in. I create an incision. Then I use a 23 gauge scissors to create a semicircle, and I bypass the fibrotic area, and then you can actually go around it. So a lot of times the fibrotic capsule can be so tense that you cannot even get with the sharp tip of the vanas inside. It's a good idea to use an MVR to pierce and create an opening, and in that opening you can get in your vanas and cut it apart.
Well, you have to differentiate between a fibrotic and a subcapsular calcified plaque.
Yeah.
If it happens to be a fibrotic one, I'm with you. But if it is a subcapsular calcified plaque, then either you remain, because that has to be separated. that is clinging onto the anterior capsule. So you have to create cleavage planes.
Absolutely,
With
within
fibrotic
inside.
parts, I'm with you. But with these calcified ones, I think the whole onus goes to, Dr. Deepak Magur, how he has opened up a new Pandora of thinking. So hats
That
off.
was an award-winning video in the AIOS this year, I remember. I was judging that. Dr. Dhami
Gaurav?
wants to add something. Yes.
Yeah, Dr. Rohit, you have shown an excellent videos. The one with the black cataract, the anterior scaffold. But with the silicone oil, removing that plaque, if you accidentally do a posterior capsule tear, you might land up in problems. If you're not
So I think
getting
Dr. Dhami sir, I also mistook that, for a moment that whether it was, he was trying to show it just the anterior subcapsular plaques and, just like what Deepak has shown. So I think I made that mistake as well.
It was
I
an
made
anterior
that mistake. Yes, sir. It's a sub-anterior capsular plaque. So
No, I'm talking about the posterior capsular plaque.
It was an anterior subcapsular plaque.
Right, sir.
Okay.
Right, sir. I also mistook it for a moment and I was confused till I realized my mistake. Ajoy hasn't spoken anything. Ajoy, how would you like to comment on any of Dr. Rohit's videos?
Unmute.
I think as Dr. Kamal said, that getting the piercing with the MVR blade, and again Dr. Rohit said they have to differentiate which are actually fibrotic capsule versus subcapsule. If you're fibrotic capsule, and definitely that thing what Rohit showed won't work. But if it is subcapsular fibrosis, definitely that's a beautiful way that he has shown. But then if it's totally fibrotic capsule, well, using a venous from 2 side, 3 side, 4 side, making it a round, I think that's the way to go in these sort of cases. Most of the time we do that. But then identification is very important. That's what Dr. Rohit.
Thanks, Ajoy. You know what we'll do? I think we are coming to a close with this meeting. I'll take a take-home message or your favorite pearl from each one of you. I will start on my screen. On the top left is Dr. Ramamurthy. So we'll quickly come out with like in 10 seconds with our favorite pearl that we picked up today. And that will be a take-home message for our audience. Okay.
Today's talk only, not in the morning.
Okay, sorry. Otherwise, we'll keep going on. So let's take a quick pearl. One quick pearl that you thought today was one of the which stood out for you. Dr. Ramamurthy. Yeah.
I think for me, the message from Hong Kong, John Chang, in the sense the way they conquered the viral problem, and in spite of being so close to China, the way the whole country rose up and arrested it. I mean, of course, beautiful pearls as far as rest of cataract complications and things are concerned, but just the ability of a country to conquer the problem. There's a lot to learn from that.
Thanks, Dr. Ramamurthy. I'll ask SriGanesh. Now he appears next on my screen. So, yeah.
I think all the videos were nice and the pearls were good. I liked Ron's videos of using the IOCT because I've been using it, and then I think it's an excellent tool. And a lot of things that we can see, like it's like the third eye. So that's something that has a lot of potential.
No doubt, it was beautiful. And at this point, before I go to Kumar to give his comment, we'll ask the audience to please send in your favorite pearl as well. That will help us understand what you thought was the most useful pearl for you. And we might even, come out with some of the comments from the audience if we have any few seconds left. Kumar, what did you think was your favorite pearl?
Think about how John managed the COVID situation, which was very interesting. I think we are going overboard here, just a simple mask, and he was talking about a surgical mask, and we thought that N95 is, everyone has to wear an N95. That's what was our take home in India. And I think what Ron, I had seen his presentation before, and how the OCT, online OCT can be used for cataract surgery was also a brilliant teaching tool. So I think these two were really shining out.
Gaurav,
So,
I would
Kumar,
like
sorry,
Gaurav,
yes, Namrata, yes.
I would also like to say I would go with Ron's presentation. I mean, it was just
Wow.
I'm
So see,
inspired,
I think
but I know this is going to be the future. It is like seeing the unseen.
Namrata, you have to influence Zeiss to make it cheaper and few other companies to start making it, huh? And you guys sitting in big institutions have access to everything, and we keep struggling trying to get our hands on these nice devices. But Kumar, I would like to point here that while take-home message should not be that you can get away by wearing 3-ply surgical masks if you're sitting in Maharashtra in Bombay with a red zone and Dharavi around the corner, and so don't get complacent with your N95. Please do wear it, and that should be the message for all of us sitting in red zones and orange zones. And let's not take it easy at all about how we approach the pandemic. We know enough cases of doctors and stuff who have got infected, and some of them lost their lives as well. So I think Dr. Dhami sir, what would you like
Gaurav,
to?
I think the greatest confidence Dr. Chang has given us is don't lose heart. You'll be back soon, and back in a very simple way. And of course, a great tip from Rohit. Mind you, very good capsular access in a very difficult situation. Thank you, Kamal, for the T-shaped incision in a white cataract. I think we have been working in a closed chamber with injecting viscoelastic, then puncturing it. In a case where we know that there are fluid spaces, we work from a closed chamber and it has worked very safe. I think your tip will take us a long way too. Thank you.
Thank you so much, Dr. Dhami. And then we come on to Dr. Rohit Om Parkash, who appears next on my screen. And let's hear it from him.
Yeah, I think, Ron, for me, has opened a Pandora box, because I now feel that, we have to have the third eye with us. And very simple, but, the tip by Dr. SriGanesh stood out for me also, because, creating a funnel and how the analog which he gave was simply, which caught my imagination for all that purpose. Yeah, thank you very much. Yeah.
Thanks, Dr. Rohit. Coming on to Ajoy now. Ajoy, what is your take?
I think it's Dr. SriGanesh's way of taking out the lens. Most of the time I would make it not trapezoid, more rectangular, to make it around 4 millimeter, both outside and inside. But then that maintaining the 2.8 outside and maybe inside 4 millimeter or 3.5 millimeter would definitely take them. And of course, Dr. Chang, as usual, so optimistic. If they have come out of it, they have their first case in January and they are back to almost normal, maybe in May with all concerns. So we should be back to normalcy by July. That's what we had our cases somewhere in February, March. So probably simple way how they did it. That's the message for us.
Well, Ajoy, it sounds simple, but I think it is actually requires a lot of discipline.
Yeah, I know they have put in a lot of things, but then there's a hope.
As I see, in my city, as the lockdown has come from the red to the orange zone, and I see no social distancing. Today, I made a short video as driving home from the clinic in the afternoon. There were about 300 people in a queue outside the liquor shop. It's been 10 days since the liquor shops opened, and we still have queues. There's no social distancing. Half of our people are not wearing masks. So let's not, get carried away by what Hong Kong achieved. They are disciplined people with the highest density of population, I think, as well, John, right? And still they managed to do social distancing. So coming on to Dr. Kudlu, let's see, Dr. Kudlu, what he has to share. Yeah, your favorite pearl.
I just, even whatever Ajoy Paul said, that every time SriGanesh comes with great innovation. This is the one point I really picked up with this trapezoid incision. I need to, even though there is no complication, I need to try in couple of cases, especially as he said that even
just put the lens in and explant it out. Simple.
We need to try.
Wow, that's cool. Yeah.
Sensor also, and as do agree with Chang, but my simple way, I was just going through one of the interview from the US and the Swedish doctor that probably India is the one country. Even whatever you say that 300 people for no social distance, still I think we'll come out of everything. I think, Gaurav, that we'll be like soon, probably June end, we'll be like normal before.
Yeah, it's always good to thanks, Dr. Krishna Prasad. It's always good to think positive. And let John, we are back to you for your pearl, and you obviously can't say that John did the best. You'll have to pick on somebody else. And why do you think the US went wrong? Now, I would love to hear your view on that. Why Hong Kong did it and US could not do it, or Italy didn't do it?
Well, I think the leadership misled people, thinking that if you wear a mask only when you are sick, as you can see, in most of the time, yes, it is true. But in this situation where this virus is so infective and is lethal, so this herd immunity cannot happen, because what we're getting now is herd mortality. I think that yes, we will get eventual herd immunity, but only through wearing masks. And I believe if you get a small dose of the virus, you don't get as sick as you get a big dose. So you wear a mask, you only get a small dose, and you have enough body time to develop, the system to fight it. If you get a big dose, that's it. You don't have time to fight. So the mask, and also, as I said, you're infected for so long, asymptomatic. So everybody's walking around. You don't know who has the virus. So I think wearing masks for everybody and social distancing that's how we did it. I mean, it's no wonderful thing. It's just everybody being strict. And I think one last thing is, educate your staff in your clinic. Tell them about this. Do the things that we were doing in the clinic, the social distancing, and teach them so they go and teach their family, so they decrease their risk of infection, their family less risk of infection. Your clinic is safer as well. And when everybody is knowledgeable in your clinic, when the patients come in, they can feel it. They can feel the confidence. They can feel the safety, and they will come. And, just by doing this, I went earlier on, I just had one patient came in with diarrhea. Okay, and diarrhea is one of the symptoms, because you can get gastric infected by coronavirus. And, but anybody can get diarrhea. The staff came in, they felt uncomfortable and said, this person has diarrhea. Instead of trying to keep the patient because I want to build my volume, I said, no. I said, let's make another appointment for him. When he comes, I will give him big discount on the surgery. So the patient goes home, everybody's comfortable. And, when he goes home and he gets rejected, people around him know about that too. So they say, oh, this clinic is very, very safe. They're very cautious. It really builds confidence. Your staff trust you. The staff feel comfortable. And the more they're exposed, the more they know about this. So educating your staff is, I think, paramount importance. And then projecting a sense of security to your patients, that you're managing everything. Everything's under control. Yeah, which is the key about a good surgeon in every situation.
Thanks, John. So you are the Jackie Chan for us. Thank you so much for all those wonderful comments and bringing positivity to us. And so Ron, next, I think Ron has to tell us. Again, he can't choose himself.
Well, I think quite clearly, I think, John, you gave us really so much information. And we kind of got COVID-19 overload from the newspapers, from the media, et cetera, et cetera, et cetera. I think what you brought up was really very relevant to all of us. We're right in the middle of it. We are reopening, and I think I learned a lot from your presentation. Thank you so much.
Thank you.
And Ron, we have all this recorded on Facebook and YouTube. I'll forward you the link.
Yeah.
You
I really want to go back and analyze what John said.
Yeah, we have the whole archive, so it'll become available right after the presentation.
Yes.
So Kamal next. Yes, Kamal, let's hear it from you.
Okay. I would say, of course, Dr. Rohit's presentation, a lot of take-home points, but what I learned from Dr. Rohit is there's a lot of stuff which we guys do intuitively, but the way he brings it out and makes an event out of it, that's what we need to learn from him. There's so much of us which we are doing so intuitively, we think it's a normal thing, everybody's doing it. Over time, we all evolved our techniques and things. So this is one thing I've learned from Rohit is to give it a meaning and throw it outwards, because it's my fallacy that I feel everybody knows how to do it. So that's one take-home point. Each time I hear Rohit's conversation, and that's when I started documenting these minor steps, because I've been doing this for the last 7 years, and that's when I started documenting in different styles. So that's one thing, take-home point from Rohit. And of course, I think the star here today is Dr. Chang. One thing I learned from him is it's different to have protocols, but consistently and persistently following them is what gets the result. We all would have protocols. So I guess the good news is, what I look forward is that he's opened up and Hong Kong is opened up. So the same way we all will open up. And I think yesterday was a good day. I did my first surgery and we had a reasonable OPD yesterday. So I think we all can look forward to a normal time post-corona. The way I tell my staff is that the era is divided into AD and BC, before Christ Anno Domino. But now it is going to be BC, before corona, and AC, after corona.
Thanks, Kamal, and for your wonderful videos. And now we have Sourabh, who's a young gun, who's going to tell us, he's again, what do you think?
Yeah.
What stood out for you?
Yeah, first of all, I think thank you very much for giving young surgeon like me a chance to, show a few things which I, learned while training my fellows. So, and I think I like Dr. SriGanesh sir's presentation, and I think he always thinks little differently. And what I carefully watched is not just the trapezoidal thing that he made, incision, but also how he was manipulating the lens with the right hand. That was a very useful trick for me. And Dr. Chang really. And in fact, we have started working routinely for last 10 days now. And thankfully, I have done quite a good number of surgeries in last 10 days. And what really is helpful is giving confidence to your staff and full PPE. So we are working in the OT with full PPE. And now we are quite confident, every staff member is confident, and that translates to our patients who are like very confident to walk in our hospitals and, get surgeries done. So I think all of us can now start working regularly. And I think Dr. Chang's message was very clear that if we take full precautions, I think there is nothing to worry about the COVID.
Thanks, Saurabh. That was really nice. When you say full PPE, do you mean, to what extent is it? Like, there are 3 grades of PPE.
Hazmat.
Yeah, it's like a hazmat. The only issue is that we can't wear the face mask. So that's the only thing I cannot wear. So we have a head cover kind of thing. But this is for the starting. So let's see how the things develop, and then we can reduce the protection.
Wonderful. So I think I've covered everyone. And, when I was designing this symposium, I was, thinking that what we might include. But it's been tremendous, and we've got to hear so many new things. And, it's been a fantastic symposium today. Thank you so much, everybody, for joining, especially Kumar, who was helping me conduct this. He's always been my companion, with all the symposiums that we've been doing. And thank you, all our guest faculty from abroad, our guest faculty from India, President of the IRSI, Dr. Dhami, Dr. Amar, who was, the brain behind the symposium, who couldn't be here today for the symposium because of some prior engagements, Dr. Ramamurthy, Dr. Ganesh, and then Ajoy for joining us, and Dr. Kudlu, who joined in, Dr. Rohit, and Dr. Mahipal had to just leave a few minutes back, Sam Masket, who was nice enough to join. And of course, all our international faculty in from the US and other places. Thank you so much. And Johnson & Johnson, who's been really behind this, they have some amazing innovations. I was hoping somebody would share, low intraocular pressure phaco, which I have been going crazy about. I would have loved to show it today at IOPs of, spotlights of 30, 35 and all, which is possible on the new machines, but for another time. And thanks everyone for joining in, and for the audience as well. And till we meet again, please take care. And thank you and good night. And sorry for keeping
Gaurav,
you
just
so
one
long.
point.
Yes,
Come on. The popularity of the symposium is 60% of the people who logged in are still logged in. From the moment. I'm getting the analytics.
Yes,
they're still logged in.
Kamal, the funny thing is, I was looking at our YouTube and Facebook feeds. We have tremendous questions, and those people who are logged in have not left us till now.
They're still there. I'm just getting the analytics. They're still there.
That's really the amazing thing, the staying part. That's what kind of struck out for me as well. And thank you so much, everyone. And gone home again. Please take care. And thank you and good night. And sorry for keeping
Gaurav,
you
just
for so
one
long.
point. One
yes,
point.
Come on.
The popularity of the symposium is 60%